what we need to do also is to ensure we hold everybody accountable. We hold the policymakers accountable. We hold the providers accountable. We will hold even the lawmakers accountable to ensure that we are able to get the value for the resources that we expend on health. So I'll be anchoring this event today alongside my colleague, Okoyemi Noluapo, that will be anchoring this event together. So let's know who is in the room. I would like to quickly introduce ourselves. And for our virtual participants, please try as much as possible in the chat box, put your name, designation, and as organization so that we'll know who is participating in this event. So before we pass the microphone around, I would like to recognize the presence of Dr. Idris Muhammad, who is the chair of the board of HEFON. You are welcome, sir. And then I would like to recognize the presence of our own Dr. Celeste Okori, who is executive director for HEFON, if I'm correct. So, so what we'll do quickly, we'll pass the microphone around. Let's quickly introduce ourselves and our designation and as organizations quickly. I would like to start from you. So.
Thank you very much. Good morning, everybody. My name is Hope Ahamba. I'm the National Coordinator of Initiative for Rural Development and Peace, IRDP.
Good morning, everybody. Happy to be here. My name is Bosede Akimbulushiri, Executive Director, Development Initiative for Community Enhancement, DICE. Thank you.
Good morning, everyone. My name is Sekina Hamza, and I work with the BHCPF unit of the National Primary Healthcare Development Agency.
Good morning, everyone. I'm by name Imuna Abdullahi, and I work with Africa Health Project Network. The vaccines and essential.
Medicine and advocacy specialist on the pneumonia control project.
Good morning. My name is Abdullahi Magama. I also work with Save the Children as a project manager.
Good morning, everyone. My name is Jamila Mohammed Gentabu, and I work with LISDEL, and I also support the BHCPF Secretariat on Knowledge Management and Communication.
Good morning, all. My name is Jamila Mohammed Ahir from Secretary, Knowledge Management and Communication, Kaduna Maternal Accountability.
Nigeria as a senior evidence advisor for the E4MMI project. Thank you.
Good morning, all. My name is Alhaji Godwin. I'm a senior manager with National Health Insurance Scheme.
Good morning, everybody. My name is Emma Bassi. I work with Clinton Health Access Initiative.
Good morning, all. My name is Igodalo Samuel, project manager in Nemo Foundation.
Good morning, all. My name is Okechukwu Ndaguba. I'm an assistant general manager with the National Health Insurance Scheme.
Good morning, all. My name is Sikiru Salawuddin. I work with National Health Insurance Scheme.
Good morning, all. My name is Abdelkadir Abdurraouf. I work with Lisa, Health System Strengthening Specialist.
Good morning, all. My name is Okara Dogara. I work for Federal Ministry of Health, Basic Healthcare Provision Fund Secretariat. Thank you.
Good morning, everyone. My name is Juliana Abude Aribo, and I work with LISDEL.
Good morning, Chairman. Good morning, everyone. Dr. Francis Ukuije, health economist, WHO Nigeria.
So thank you very much for introducing yourself. Before I move to the goodwill messages from our partners, let me further add to the stage that we've already said. This process actually started some years back, like 3-4 years, where a sector reform coalition set up a financing subcommittee, and that committee was saddled with responsibility of doing a lot of things, including developing accountability framework, and Health Fund played a very, very important role. We actually reviewed the existing evidence, tried to develop a draft document. We had a series of engagement with partners, and this is a continuation of the exercise. Hopefully this time around, we are going to have a lot of traction and to make us achieve the objective. So I would like to invite some of partners here that are supporting the process to give the goodwill messages. So I would like to invite Dr. Francis Okuije, who is representing the World Health Organization. Dr. Francis, over to you.
Thank you very much, Dr. Gafar. Chairman, my colleagues, I bring you greetings from the WHO Nigeria representative, Dr. Walter Kazadi Mulumbo, and to say that WHO is fully in support of developing accountability framework for health financing and basic healthcare provision fund in Nigeria. In previous occasions, the WR had made pledges to the government of Nigeria through the Honorable Minister of Health for WHO to support this. The reason is very simple. As laudable as every initiative is, if it is not implemented, it's not going to achieve its set objectives. And the Basic Healthcare Provision Fund health financing in Nigeria, we believe that the Basic Healthcare Provision Fund is the game changer in health financing reforms in the country. And we believe that if we are able to have a system that will track progress while holding the implementers accountable, that it will really make a lot of sense. As much as we know that civil society is not a police or an investigating part or investigating body for government. Sometimes a lot of people misconstrue the role of the civil society. We actually recognize civil society as partners in progress, partners towards achieving the roles of government. And actually, because of the collaborative leadership we see in universal health coverage, we cannot overstate the role of civil society, even in this accountability framework. So we are happy to be connected and committed to this process, and WHO will continue to support this until we see that we have a system of accountability that is working in Nigeria for health financing and basic healthcare provision fund. At this point, I want to congratulate you once more. We believe we are going to have good deliberations, and that the objectives for this particular stakeholders meeting will be met. Thanks a lot.
So thank you very much, Dr. Francis. So the watchword is the accountability system that works. We will take all the goodwill messages, then we'll hear from our father in the house before he gives some opening remarks. In this southwest of the country, they said, is the biggest masquerade that actually dances last. So let me invite the executive director of legislative initiative for sustainable development that's playing very, very important role, providing a huge amount of resources to support this. So I would like to invite Juliana Aribo-Abude to give you some goodwill message. Over to you.
Thank you, my Oga, Dr. Gafar. He's actually my Oga. Good morning, everyone. It's really great to see you here, and I hope that you all slept well. Please permit me, Chairman, to stand on existing protocols already established by Almighty WHO. So who is listed to speak when WHO has spoken? I will just build or ride on the momentum that Dr. Francis has already established to say that I've been a member of the Health Sector Reform Coalition for years. I think since it was established to lead the enactment of the National Health Act in 2013. I didn't go for the march because I was pregnant with let me not tell you the number of the child so that I was pregnant with one of my plenty children at that time. So I couldn't go for that march in 2011, not 2013. So it's really gratifying for me to see that we are here today. We developed the health financing framework shortly after in 2018, and had participation as we have today from the sector generally. And although we haven't been able to develop an action plan for the health financing framework as it is, the accountability framework itself is really very comprehensive. And that's why we are working to see this basic healthcare provision fund accountability framework be derived from it. In collaboration with HEFON and the Basic Healthcare Provision Fund MOC Secretariat. I would like to, I know it's a goodwill message, but let me just put a charge in it, charge all of us, because I'm a member of the committee as well, to this time, to not let the ball drop and perhaps not also sit back to complain that HEFON is not doing what it should be doing, because we are all members of the Health Sector Reform Coalition. And once we have these documents, we should be able to do something with it for ourselves, not just as institutions represented as members of the Health Sector Coalition or as institutions that work in the health sector, but for us as Nigerians. This is Nigerian led with some support from partners like WHO, the Gates Foundation, AHBN and others. But first and foremost, let's do this as Nigerians who are willing to see the health sector work and to hold ourselves to account, and not just the government, but to hold ourselves to account to ensure that this is operationalized. Subsequently, we hope to have a dashboard where we will upload results from tracking and every other thing. And we look forward to the processes that will come out of this 2 days workshop. So I wish us all successful, fruitful deliberations, rich conversations. I look forward to this, being mindful, of course, of the time, and also what we will do with this going forward. Thank you for being here today. Thank you.
So thank you very much, Juliana, for that succinct. So let me invite African Health Budgeter Network to quickly give a goodwill message.
Thank you, Dr. Gafar. Good morning, everyone. My name is Maimuna Abdullahi, and I'm representing the coordinator of Africa Health Budget Network. He is currently unable to make it for this engagement, but then he sends his regards to all the stakeholders present. AHBN is very excited to be participating at this very important engagement today. And our work at AHBN focuses on improving and strengthening health financing accountability in Africa. And therefore, here in Nigeria, we are also committed to support the Nigerian government to ensure that we have an accountability financing system in place. We would like to align with other partners that the importance of health financing accountability cannot be overemphasized, and therefore having a harnessed health financing accountability framework is very important, as this is going to help all the implementers to be held accountable. We would like to encourage all the stakeholders present today to be very dedicated in order to ensure that by the end of the 2 days workshop, we have all the stated objectives attained. And with this, we would like to wish all the stakeholders present a very successful deliberation. Thank you.
Great, thank you very much. I don't know whether West African Public Health Institute is here. West African Institute for Public Health. Online, so should we take we would like to take the goodwill message of West African Institute for Public Health. Can we allow them to speak, please? So probably where we're still sorting the technology over there, I have DJI consult as well. So on this note, I will switch my hat to somebody that will give a goodwill message, not the anchor at this time. So I represent a DJI Consult, organization that that is established to promote good governance in development sector, including health. And accountability is one of the areas that we attach, one of the areas we attach great importance to. We are part of this process from the beginning, and we are happy that we are gaining traction. We are far more interested in seeing accountability framework that works, like Francis said, and not only at the national level, state level, but at the facility level where the people are supposed to be getting access to healthcare without suffering financial hardship. So we wish all the stakeholders a good deliberation, and we look forward to the very good outcome of this process that will take us to improving the accountability bar or raising the accountability bar in the health sector. So do we now have WAF? Okay, not yet. So on this note, I would like to invite Dr. Idris Mohammed, the chairman board of HEFON, to give us the opening remarks, to give us a overall vision of HEFON for improving the accountability bar in the health sector. Over to you, sir.
Good morning once more to every participant here present this morning. I want to specifically recognize Dr. Francis from WHO, Juliana from Lisdale. Dr. Mogashi is not here, but she sent a representative, the African Budget Health Network, and all other participants at this meeting. Once more, good morning. Most of the times when I'm invited to give any kind of a remark, I'm always conscious of the time. So in order to avoid unnecessary distraction, health industry. Accordingly, the following are some of the objectives of the workshop. I believe the agenda you are given has those objectives already listed. So I wouldn't bother to go through them, but to stress the point that as CSOs, our need and aspirations is really to collaborate with state actors. I think time has come when we should be talking about partnership and not working on islands. We will never be able to achieve a robust health system we have as a country. So, distinguished ladies and gentlemen, you will agree with me that the workshop is very important. It's an important event. Therefore, I wish to call on all of you to participate fully in this workshop. The need for active participation by all is informed by the fact that the desired accountability landscape would remain a mirage without a robust accountability framework for health financing and to provide guidance on what information we wish to collect along with the health financing mechanisms and how to use such information to hold different actors accountable. If you recall, the WHO representative really listed all the actors, and I want to reiterate those actors. Not only the state actors, government and their affiliations, but also the CSOs and partners and donors. In fact, everybody must be accountable. And for us in Nigeria, I think this is what we're missing at the moment. In addition, I believe that all stakeholders need to agree on a systematic approach for the collection and use of information on government health spending, prepayment mechanisms, external health financing, and other innovative funding sources, and the use of such information to ask relevant questions that will lead to a change of policy and practice, thereby improving accountability on the part of all stakeholders involved in health financing. Here in Nigeria, we know that a lot of money is being spent, even though we're not able to meet the 15% budget suggestion by WHO, or which we actually have agreed to in Nigeria in 2001. The point is still that the little that is available to health resources in Nigeria certainly there's no accountability for it. And much of what we do not speak to the amount of money that we are using. So the need for this accountability framework becomes very necessary. Before I conclude my opening remarks, kindly permit me to, on behalf of HAFON, the Health Reform Coalition, to thank our supporters, WHO, LISDEL, DGI Consult, and even the Federal Ministry of Health. We appreciate the gesture, and we really appreciate this generosity and the collaboration to partner so that we can have a unique accountability framework for health care financing that will be acceptable to all of us and we can use for betterment of the funds allocated to health in Nigeria. we would like to assure you that HAFON, along with Health Sector Reform Coalition, will do all that is possible to do in order to implement whatever decisions we reach at this workshop for the benefit of all. Thank you very much for listening, and I thank you for your time.
Thank you, sir. I think Mr. Chair deserves a stronger round of applause, please. You said a lot of important things, but one thing that actually struck me was that even the resources that we have in the health sector is not buying the best the money can buy. So there's a room for improvement. I was told when I was very young that the largest room in the world is the room for improvement. So it is to achieve that improvement. That's why we are here. So I would like to recognize the representative of the various basic care provision fund gateways present here, the National Health Insurance Scheme representatives, the National Primary Care Development Agency, representative of the AMT gateways, and the National Center for Disease Control. You are welcome. We look forward to having very, very fruitful deliberation. So before we proceed, we would like to know why we are here, to set the objectives, because one of the most important things in accountability is to set the objectives so that it forms the basis for holding ourselves accountable. So I would like to invite Okoyemi to quickly give us the objectives of this forum. Thank you.
A very good morning to you all. Standing on existing protocol, I will just go straight, especially for our online participants. The workshop objectives. Number one is to deepen the knowledge of participants on the concept of accountability in the health sector. The second one is to acquaint the participants with the Health Sector Reform Coalition Health Financing Accountability Framework and validate the framework. The third is to harness experiences from existing accountability initiatives in health sector generally and on the Basic Health Provision Fund in particular. And the fourth one is to forge a consensus on essential elements of Basic Healthcare Provision Fund accountability frameworks, including institutional arrangement for coordinating the Basic Healthcare Provision Fund accountability related activities. And the last, but not the least, is to develop an action plan for the design, deployment, and knowledge management for the Basic Healthcare Provision Fund accountability framework. Thank you.
Okay, thanks. Let's appreciate him. Okay, that's good. So, okay, let me just give us the objectives of this forum. I think we've set a very, very huge, very big target for ourselves, and we have to work towards achieving all those. The next thing on the agenda, I was told the representative of the Federal Ministry of Health is not yet here. Dr. Uzman Wankwo, is he here? Okay, not yet. Oh, sorry, I was misinformed. So now we are talking about accountability for health financing. Before we know why it is important for us to raise the accountability bar, we have to know the status of financing. We have to understand the landscape. We have to understand where we are in terms of volume of funding, in terms of efficiency of funding, in terms of is the money actually buying what it intends to buy. And to do justice to that, we have in the house, Dr. Uzoma Wankwo from the Federal Ministry of Health, Health Financing Unit. Dr. Uzoma Wankwo will be making a presentation on Nigerian health financing landscape so that we have a better understanding. Let's appreciate him. Somebody says it's only in Nigeria that we appreciate people before they do the work. But notwithstanding, let's still appreciate him. So over to you. Let's upload his slide deck, please. Can we project his slide deck, please? Okay, Amy. Okay. So I'm sure they will do that very soon. Doc, over to you.
Good morning, everybody. Is it possible to use this screen as well? Because some of the slides have data and graphs on them, and I don't think you're going to appreciate it very much from this, at least for those who are physically here. Do I wait a little bit, or do I could. I'm just pointing out that when I get to the place where it gets very interesting, people will not see. All right. Okay, so good morning, everybody. My name is Uzoma Wanko. I head the Healthcare Financing, Equity and Investment branch at the Federal Ministry of Health. I'm glad to be here. And as you know, those who were at the technical working group meeting yesterday, one of the very important conversations were around accountability for the Basic Healthcare Provision Fund. It has been an ongoing conversation. Government is pulling in about at least 1% of consolidated revenue for health. And therefore, there is the Secretary of the Ministerial Oversight Committee. One of the challenges is pointed out was some level of interference and whether funds were really going into what they were meant for. And I think that those of us who are in the healthcare financing branch, at least at the Federal Ministry of Health, one very important thing we do is expenditure tracking to show what happens across healthcare financing landscape. So today I'm going to be speaking to those issues. But first, whenever we have opportunities like this, we recognize the fact that health financing is a little nuanced. So we try to use every opportunity we'll have to bring people up to speed around, basic concepts of health financing, because a lot of people tend to support people at subnational levels. It's always important to, again, remind people of what the basics and fundamentals. So please forgive me. I'll just run quickly through a couple of things that are really important, and then we'll dive into the substance of the matter. Next slide, please. So like I said, I'll just go through some concepts and then we'll talk about the strategy and landscape. Next slide. Next slide. Thank you. A lot of us are familiar with this, the graphics you have on the screen, the Sustainable Development Goals. Sustainable Development Goal 3 speaks to universal health coverage. And of course, universal health coverage is a terminology very well known to people in the health sector generally. And for us, specifically in healthcare financing, it is at the heart of a lot of what we do. Next slide. And the UHC cube, at the heart of health financing again, something that any person who is involved in health financing in any capacity at all, be it in supporting implementation or in developing policies, it's important to know everything we're trying to do tries to achieve in universal health coverage what you see in this box. And the idea is that you have a bigger outer cube that represents all of the health that every person, if we're speaking about Nigeria, every person in Nigeria will require. If you look at the horizontal flat line on the x-axis, you would see that you have a population of people who are covered. That represents how many people, whatever you're doing, what sorts of things you're doing, how many people are you reaching? The small cube in the middle shows you, as an example, some fictitious country or state, what it is doing currently. And the goal of everybody is to try to expand that smaller cube in the different dimensions so that it continuously, progressively fills up the box. And the ways to do that is to cover more people. The benefit package you have, expand it in a sustainable pattern so that it covers more services. And in terms of out-of-pocket expenditure, you reduce the amount of monies people are able to pay out of pocket in terms of cost-sharing fees. This is at the heart of what we do in terms of health financing and the drive towards universal health coverage. I always like to show this slide because understanding this slide tells you all the story. Next slide. Now, there are healthcare financing functions. To be able to achieve what I showed you in the previous slide, you would obviously recognize that there is a need for us to raise revenues, pool the revenues together, and then purchase the services. In the subsequent slides, I'll speak to these functions in granular terms. Next slide. Next slide. So in raising revenue, we're referring to, next slide, please. We're referring to all the other strategies for which we use to get the money for the interventions. Now, just before I go to that, the whole idea in financing is we try to answer these questions, basic questions of who is paying, how much is being paid, who are we paying, and what services is it that we're paying for, okay? But at the heart of it is the money, right? Next slide. Now, this is a spectrum of what we had spoken to. It is important to raise the revenues, get the monies, now the strategies for health, and this is why we usually at opportunities like this speak to this. A very, very important part of everything we do is risk pooling. And I would tell you later in later terms why it is really key. Revenue raising, monies for health, where is it coming from? Government budgets, insurance, donors, philanthropic agencies, all of them. But what do we do? How do we use financing mechanisms and measures to be able to operationalize it for health? Next slide. Next slide. Good. So in order to achieve universal health coverage, how much is it really going to cost? How much are we really looking for? There have been a lot of work on the impact of health and the economy. Professor Jeffrey Sachs in 2001 led a commission on macroeconomics for health, where it was determined that you needed about $34 per capita to be able to achieve some basic level of healthcare for an individual. And since then, there have been other efforts. One of them, and you see a lot of them on the screen. I'll just pick a couple that are important to our conversation. Here, where we put new with the star, is an effort to calculate the cost of basic universal health coverage benefit package. And it is put about $86 per capita. Now, but for those of us who are in Nigeria and in the African region, we are all familiar with the Abuja Declaration, something that is easy to figure out. How much do we think people should contribute for healthcare? The governments of African regions determine 15%, and that's something we've been struggling with till date. Arguments are replete around the fact that health expenditure is embedded in other sectors, and therefore, if we just look at the Ministry of Health budget alone, we're not correctly calculating it. Those arguments have been advanced. Arguments are that health is concurrent, it's spent across all levels, and therefore we need to be able to take all that into account to determine whether government is in up to 15% or not. Next slide. But the point is that these are valid questions for health. I spoke about revenue collection. A lot of the economic analytical work we do at the healthcare financing team estimates all of these indicators you see on the board: out-of-pocket expenditure, general government revenues, externally financed, and insurance. These are mechanisms for raising revenue. There is the very, very common and really broad assumption whenever people talk about universal health coverage to relate it with insurance. That's wrong. Everybody tends to think that even everybody in Nigeria, insurance is just one, even small, it's even the smallest mechanism for moving countries and nations towards universal health care. Although that also depends on the model, especially in a country like Nigeria, where we have the huge informal sector. Okay, but we recognize that. Next slide. This is, I thought to put this slide. This slide is borrowed from the Ministerial Oversight Committee Secretary. It shows us one of the biggest, boldest endeavors of the Nigerian government to finance health and raise additional revenue for health, where government is putting down at least 1% of consolidated revenue fund for health. These are the different gateways. When Dr. Chris speaks to us later, she's probably going to delve deeper into this. I guess we're all familiar with this, but this shows you that a lot of money is now going into health, and therefore the need for us to think about how to make these processes accountable. Next slide. Now, risk pooling. Next slide. Next slide. It's not sufficient. Next slide. Next. Thank you. Please go back one. It's not sufficient to just raise these funds. all of us in the room have jobs. We're arguably able to take care of our health, but there is a component of financing that has to do with equity. And that is also tied to the accountability questions. Those who are entrusted with the resources have an obligation to ensure that funds are used equitably. There's a concept of equality and equity, and I think we're all familiar with that. But the idea of pooling is that we're gathering this small income together into a basket of resources so that that's 10 to 30% of people who usually require healthcare at any particular point in time can use it. Very young people. Next slide. The reason why this is important is for cross-subsidization of risks, right? Based on health needs, there are young university students who are very healthy and arguably in their time in the university might never even need healthcare except maybe treat malaria, paracetamol or something. But then you have senior citizens, the university lecturers in that same community who can have heart diseases, diabetes, who would plunge into healthcare expenditure. If you do not bring these groups together and cross-subsidize risk between healthy and sick, and between rich and poor, and of course the aged and the young, then you miss the idea of healthcare financing. These are important as we work with subnational levels, as they set up their state health insurance schemes, as they utilize the Basic Health Provision Fund to achieve and drive home the equity goal. Next slide, please. These basically are just writing what I had just spoken to. Next slide. Yes, and then when you have gathered these monies together, what do you do with them? Purchasing. Now we're going beyond just discussing purchasing, but we're talking about purchasing in a strategic manner, strategic purchasing. That supposes the ability to make the systems of purchasing a living process. That means you're reflecting the realities of the current time in which you are in. You're not rigid and just holding on to what you have done before. So purchasing, strategic purchasing is one of the important functions. Next slide for health financing. Next slide. Next slide. These are all there for us. So this is the issue comparison between just purchasing and strategic purchasing, which I spoke to. Next slide. Okay. So I've just tried to scan through very quickly some basic concepts of healthcare financing. And now I'll be going into taking you through the landscape for financing. At the Federal Ministry of Health, after the National Health Act came into being, this document, the Nigeria Health Financing Policy and Strategy, was developed, and it outlines strategies for the country to achieve, some of what is outlined in the National Health Act, including the financing policy and objectives. Next slide. Next slide. Okay, so in a lot of the work that we do at the Federal Ministry of Health, in trying to point and guide the work of health financing across the country, we additionally, for a long while, been conducting studies called the National Health Account Studies. The Health Account Studies is an expenditure tracking effort. It's an endeavor to ensure that funds that are allotted for health are properly accounted for. Now, these are not budgetary estimates. They are not releases. They are expenditure. Very different from tracking, oh, government A has released this, government B has. We're talking about how it was spent. And to be able to generate this data, we triangulate a lot and use validated reports from auditors, auditor generals of the country and across states and LGAs. And if you look at the screen, you will see a lot of indicators. Without spending a lot of time taking them one one after another, you would see that every year from 2015 to 2019, some progress is being made. But let me just point out one. So a couple of them that I think would be useful for our conversation. So the first one is total health expenditure as a share of GDP. You would see that from 2015 to 2019, we have not exactly made a very tremendous progress, even as our GDP is expanding. We rebased the GDP recently, but healthcare expenditure did not dramatically also follow what we saw in GDP. The other important conversations around financial risk protection is how much money is the ordinary citizen paying for health? And that is the per capita out-of-pocket expenditure. In Naira terms, you would see what that is per person. These slides are there, so you can dig deeper into them. Next slide, please. Now, this is a comparison of Nigeria in the Committee of Nations in the African space. Unfortunately, my pointer is not showing on this LED screen, but Nigeria, it's arranged in alphabetical order. So after Niger, you see Nigeria really dwarfed amongst the other countries. And this is for 2000 and 2016. This reflects what proportion we're spending on health. Next slide. Again, this is another comparison of government expenditure on health as a percentage of total expenditure. Of total health expenditure. So how much is government spend? What is government's contribution in the equation of total health expenditure? If you look again, you will find Nigeria somewhere. Just look for Niger and Nigeria. You see where Nigeria stands, and you see how other nations tower well above the efforts that we make. Next slide. But keep in mind that these are really things that we hope that the BHCPF is able to change with its implementation. This gives you an idea of the African region again, and this is domestic general government health expenditure as a percentage of general government expenditure. That is all of government spending across sectors, health compared to that. And you see, this is not arranged in alphabetical order now, but you find Nigeria in front. Okay, you find us somewhere there. Next slide. Okay, so how much are we spending per capita and for health? Remember in my initial slide, I had said that there was a study done to calculate that what was required was about $86. At least to be able to achieve that benchmark of UHC. This shows you across 2010 to 2019, how much we have been spending. We are way below that benchmark. And it is important for people to know this so that as we, spend more, we're spending it in a strategic pattern, and that we are calculating and holding people accountable for the resources that goes into your next slide. We also try to group states in Nigeria across the 6 geopolitical zones, just to also give us a semblance of what states are doing relative to what is happening nationally. This is for the North Central zone, and you would find the different states there, and you would also see how they compare with one another. Keep in mind that none of these spending is up to $85, which is in today's term somewhere around 50,000 Naira. Okay, so you can, any state you're interested in, you can just have a look and see how this is from 2017 calculations we did. So next slide. I'm still showing this because it's not significantly different from what's happening today. You would again see the different states. This is for Northeast. Next slide. So on the legend on the right, you would find those names that you can't quite see. The first is Jigawa, Kaduna, Kano, Katsina, Kebbi, Sokoto, Zamfara. The last one is Nigeria. Again, you find how expenditure is happening. And, so the reason why I thought to show this is that documents like this and outputs of the National Health Account studies like this are very useful advocacy tools. If you put up stuff like this in the right audiences, people who are there would ask questions and could trigger some reaction that could further impact on health. Next slide. This is for the Southeast. And again, you would find how states are performing in the Southeast. And the next slide. But this is for the South-South. Now, so this data represents a point in time, right? For 2017. It's not showing you a trend of these states over years. So when you're interpreting it, know how to, it's for the following year. Other states may have performed better than the states as they currently are, as you currently see them. Next slide. And this is for the Southwest. Okay, so the idea is to show you what your efforts, partners who support work across states, what it comes to. We would go in subsequent slides to look at programs, disease areas, and just see what this money is really meant for. Next slide, please. Right, so these line graphs show you who is really spending money in health. The very first line you have up above represents out-of-pocket expenditure as a proportion of current health expenditure. It has always been up there in the 70s, in percentages of 70s, upwards and above over the years. The blue line shows you government expenditure on health. The red line shows you donor funds from outside of the country. And the yellow line underscores the point I made earlier on, insurance. Both the social health insurance, private health insurance, and everything we're shouting about insurance. That's the yellow line. So you can see at this point, health insurance is not yet mandatory. If it becomes mandatory, then perhaps the line is going to move above the other two lines. And we hope it's going to bring down that line up there. Next slide. Next slide, please. Next slide. Okay, so what's all of these funds that goes into health? What exactly are they used for? Now, the pie chart to my left would show you that a significant proportion of funds expended in Nigeria are for communicable diseases, 61.4% from the 2019 health account studies, 61.4%. However, we have non-communicable diseases now increasing, as we all know, because of disease demographics and epidemiology, 12.1%, reproductive health, 10.5%, and of course, injuries and some other non-specific causes. Of the proportion of communicable diseases, if you look at the pie chart on your right, you would find that the expenditure on malaria takes up about 36.2%, of course, followed by TB and HIV/AIDS, in keeping with the global priority around the big three diseases because of all the attention that they get. However, we also have spending on vaccine preventable diseases, a 4.7%, diarrhea diseases, and the rest. Next slide. Next slide, please. Now, significantly over the years, as we conduct health account studies, we keep seeing that expenditure consistently on the current health expenditure consistently dwarfs capital health expenditure. We are trying to keep projecting this out there so that policymakers and those who spend resources on health can maybe change the dynamic a little bit. Next slide. Next slide. And this also shows you the different categories of expenditure: medical goods, curative care, preventive services, governance and admin costs, rehabilitation, and long-term care. This reflects the different proportions of expenditure. Next slide. Now, primary health care, because of the Basic Health Provision Fund. The two lines you see show you the expenditure, one on primary healthcare services, and the red line shows you the proportion of those spending on primary healthcare services that occur at the primary healthcare level. So whereas people are getting primary healthcare services, most of the expenditure is happening at the secondary and tertiary levels, therefore removing all of the investments that could have happened at the primary healthcare level. Next slide. Okay, so with that last slide, what I had tried to do is to rejig our memories and brains a little bit on what healthcare financing is and what we hope that the result of all of the work that we do across states, nationally, and across the partner groups is in terms of universal health coverage. I've also been able to remind us of the National Health Act and the healthcare financing policy and strategy and all of the strategies and activities it outlines. And I've shared with you the data from the National Health Account studies that are conducted every year. They are publicly available in the Federal Ministry of Health's websites across the years from 2010 till date. And these are exercises that are ongoing, and to appeal to all of us when we receive calls for this exercise for data so that we can calculate this correctly, we should please do endeavor to respond to us. And to say that the exercise, this workshop and the accountability framework that is being developed is at the heart of what we had just presented in ensuring that the funds meant for healthcare do indeed get to those for whom it is meant. Thank you very much.
Great, thank you very much for that very, very powerful presentation. Shedding light on the health financing landscape in terms of policy landscape and at the same time in terms of performance landscape. I think you can summarize the performance landscape by saying in terms of how much we are spending, we are not doing very well, we are not there yet. In terms of who is spending, we are not there yet. And in terms of even the little amount of money that we are spending, what is the money buying? Put side by side, what can the money possibly buy? I think there are a lot of issues in there. I'm very sure some of us have questions, clarification, and contribution. I suggest we note our questions and contribution. The same applies to our virtual audience. They should try as much as possible to put their question and contribution in the chat box. We are going to visit those questions, and I'm very sure the doc is still available to answer those questions. Before we go for tea break, we'll take one more presentation, and then after which we will allow those that came in after the first set of introduction to introduce themselves. So we are going to take a presentation on the design and utilization of HSRC accountability framework. Please let's upload the presentation. Or while they are doing that, should we take introduction of those people that? Okay, that's not the presentation. Huh? Okay, with introduction. Okay, so that's the consensus. Okay, great. Because this is democracy. Any new come here? Okay. Okay. Doc, want to introduce yourself?
Morning, Dr. Gafar. Good morning, everybody. Chairman Hefon, other dignitaries here present, fellow attendees. My name is Dr. Henry Ewunono. I am here on my own. I could have been here on behalf of Nigeria Medical Association. I've not been given the final pass to say that, but for now, I'm here on my own. It's refreshing seeing some faces again. Thank God COVID did not win. So let us use that energy, renewed energy, the warmth, especially at this auspicious time, to wake up everybody to talk about health. They have 100 million naira to pay for form like this. The health center in my village, there is none of us that the ladies can never enter there to deliver. I will never allow my daughter, my wife to deliver there, but they have money to pay for 100 million, 40 million, and so on. Because we have allowed them to be. I will stop here now, sir. Thank you.
Thank you very much. Okay.
Good morning, everyone. My name is Bello Halima Titulokwe, the Information and Youth Engagement Officer of Africa Health Project Network. It's nice to be here.
Oh, sorry. Any new procedure? Okay. Any newcomer? Okay.
Ms. Rachel Chidmobi from Center for Environmental Sustainability and Development Awareness. Thank you.
Morning, all. I'm George Monye from Majesty Community Rural Development Foundation, Majesty Foundation, and the Executive Director and also member FM.
That sounded like Manchester.
Good morning, ladies and gentlemen. My name is Edwin Jekeli from the House Committee on Healthcare Services, National Assembly.
Morning, everyone. My name is Sati Marcel from the Budget Office of the Federation.
Good morning, everyone. My name is Yahya Mohammed from Health Strategy and Delivery Foundation.
Good morning, everybody. My name is Ifoma Chukwumerije from Health Systems Consult Limited.
Good morning. I'm Dr. Zara from Health Systems Consult Limited also.
Good morning, everyone. My name is Frances Ilika, Country Director, USAID Funded Health Policy Plus Project. Happy to be here.
Bejide is my name, Health Reform Foundation of Nigeria.
Morning, everyone. I'm Rosemary Ayu, Clinton Health Access Initiative.
Okay, thank you very much. And so our virtual participant, please don't forget to put your name, designation, and your organization in the chat box as well.
Good morning, all. I'm Inu Salisu Adamu, National Primary Healthcare Development Agency.
Good morning, all. My name is Hassan Ibrahim from National Primary Healthcare Development Agency, BHCPF.
Good morning, everyone. My name is Anu Rotimi from Center for Accountability and Inclusive Development, CAD.
Okay, thank you. Thanks for introducing yourself. So we'll be taking a presentation on the design and deployment and implementation of a HSRC accountability framework. Can we go to the next slide? Can we show it on the monitor here as well? Okay, thank you. So next slide. I'm very sure all of us are familiar with the concept of accountability, but the interesting thing is that accountability means different things to different people. So it's very, very important for us to set the stage in terms of what are we talking about, and then look at the framework that the HSRC has developed for health financing accountability, and look at how we have used it as so far. Next slide. So in terms of setting the stage, somebody says if you want to understand a concept, understand the caption first. So when we say accountability, so there are two root words there, account and able. So which is simply talking about how do we hold ourselves responsible for our actions and inaction. As simple as that. Of course, there could be a complicated definition and everything, but basically here, we are talking about how do we hold ourselves responsible for our actions and inactions. But again, for that setting the stage, if you look at the history of the world itself, even those developed worlds today, they migrated from a realm of impunity to the realm of accountability. And when countries are developing, when mankind are developing generally, two things are actually changing their lives. as a society. Then they tend to move from impunity, that Sati, I'll kill you, nothing will happen, to if I do anything, the system will hold me accountable. And the second thing that is changing in their life, they are becoming more equitable. They are thinking about everybody in terms of everybody having access to good things about life. Again, in terms of accountability, society becomes more accountable when there is freedom of speech, when people can speak and they can ask questions and they will get answer. But you know the interesting thing? As a child, children tend to be more accountable than adults because they tend to ask questions and they demand an answer. Recently, I visited a family and the son was asking the mom, "Mom, why are you changing your driver every year? In 2020, you employed Andrew. In 2021, you employed Lukman. In 2022, you employed David." The mom said, "Shut up." And that is what we see commonly. You understand? We tend to, as much as possible, make people not to be accountable, to minimize their voice. And I told the young lady, you don't tell this child to shut up. Try to give this young guy the explanation. Try to explain to the young guy that, do you know what? We have other domestic staff in the house. We did not sack them every year because they are doing very well. These people that we actually sack, whatever, they are not doing well. So when people are doing well, keep them. When they are not doing well, kick them out. And the mom really appreciates it. But if you look at how all of us grew up, maybe because we are not accountable today because our parents actually suppressed our ability to ask questions. I'm just still setting the stage. And again, if you look at, if you want to be effective, you want to be efficient, you want to be equitable, we must ask right questions. We must demand answers from everybody. And somebody says, do you know what? Most of the traditional rulers in Africa, there is a name that is common to them, at least where I come from. So it will resonate with some of us from southwestern Nigeria. It refers to traditional ruler as somebody that can never be asked a question. Ask him no. And it's not just about traditional ruler. It's an elitist something. If I'm powerful, nobody dare ask me a question. And that is the origin of impunity. That if I do it, nothing will happen. And we're just setting the stage in terms of where we are coming from and where we are having this type of problem we are having. And it's not only about health financing, it has implications for development generally. Next slide. So when we say accountability, let me go through some typology in terms of what types are we talking about. I don't dwell too much on that. But depending on who the actors are, depending on the focus of accountability, and depending on the subject of accountability. So we have political accountability where we hold our political class accountable, that if you are not doing well, probably we won't re-elect you. How well we are doing that, I'm not very sure, in terms of whether the voice determines whether somebody will be re-elected or not. Ideally should be. Financial accountability where financial control is the focus. Social accountability where the community themselves are holding the system accountable, are holding health providers accountable, that we are not providing the services and all those stuff. Bureaucratic accountability where okay.
I'm sorry, but can I ask? Apologies, guys. Good morning. People with my glasses, I can't see.
Yeah.
So please, can you ask me?
So let's hold their hotel accountable. So let's hold them accountable because we actually paid for this to get a clearer resolution. In the interim, maybe we can switch off the light. Okay. Absolutely. So let's raise the accountability bar. Okay. So the hotel, let's do the needful so that people will see. That should be closer. Great. But in the inside room, can we switch off the light? Probably it will help. It will not. Okay, the camera people don't like that. Okay. That's great. So somebody is attending to that. Thank you very much, Dr. Iwekwe. Yeah, I'm very happy to have you here. So I was talking about in terms of typology. So we've talked about different types and legal accountability because we have legal framework. There are a lot of laws. Somebody said, you know, there's no respect for the rule of law in this part of the world. That's the truth of the matter. Because there's no legal accountability. Nobody is holding us accountable for what the law says and as much as possible. But what is important, functionality as it applies to about. We need the combination of bureaucratic accountability. Okay. So next slide, please. I'll try to slow down so that we don't miss much where we're trying to rearrange get the technology right. Next slide. So again, what is the rationale? Why are we talking about accountability for health financing? In health financing, you can remind me, slogan in health financing is about two things. You can remind me, please. Not Francis, though. Who can, not Francis and Francis. We have a slogan in health financing. Nobody wants to help me out. Basically, it's about more money for health and more health for the money. Everything that doctor mentioned about health finance is just about two things. We want to spend more money and want to get more results for the money. Now, the level of accountability bar determines to what extent I will be able to raise more money. And it determines how we are going to spend the money well, whether we are going to spend the money well or not. So I won't go too much into statistics. The doc has already told us we are not spending enough. Across all the benchmarks, somebody says, if you want to achieve universal coverage, if you look at those that are making progress in that direction, what they are spending, we are not spending that way. That means we have to do something. So I don't go through each of the indicators one after the other. The summary of it is that we are not doing well across all the indicators, whether in terms of spending as a proportion of health spending, as a proportion of government spending, whether per capita spending, and the proportion of the GDP. That's why it's even the worst, because for country to make progress in the direction of universal coverage, it's recommended that they spend at least 5%. Government spend 5% of GDP. It's not only the money that everybody is spending. We are more interested in what the government is spending. It should be at least 5%. Nigeria is doing less than 1%. So that sets the stage in terms of spending enough. We are not spending enough. But how does accountability comes in when it comes to spending enough? In terms of government allocation for health sector, if you talk to them, Ministry of Finance, they tend to 30 is here, is from the budget office. This is the man that has the knife and the cake in the budget office. And they will tell you that spending in the health sector is like a black box. You don't really exactly know what they are spending money on. So we want to spend more money in that respect. In terms of earmarking money for health, there is ongoing debate around the sugar tax, the additional 10 naira per liter that is added on beverage, on our drinks. Do you know that elsewhere, when they earmark such money, it goes to health directly. But the chief in the budget office says, no, We are going to earmark the money in Nigeria, but it's not going to the health sector, it's going to the central pool. We now say, why, Oga? Because Oga has the knife. It's Sati's boss that I'm talking about. And he has his own reason. He said, when you give earmark money for the health sector, they evade financial scrutiny. And you are not able to ask them questions, how you are spending this money. So as a result of that, the sugar tax will collect it, your eyes will see it. At the same time, somebody says there is even different in Nigeria, there is a difference between, they say earmarking is earmarking. But what is more important is handmarking. So you earmark, but you don't handmark. So that is why accountability is important if you want to spend more money on health. What is even more important is efficient utilization, next slide, of the amount of money we are spending. Why is this important? A number of countries spend exactly the same amount and they get different results. Some people spend lower amount of money and they get better results than us. Efficiency. So if you look at this chart, each dot you see there represents a country. On the vertical axis is under 5 mortality, and the horizontal axis is looking at amount of money countries spend per capita. In summary, you just see that the arrow is pointing to where Nigeria is. This arrow is pointing to where Nigeria is. Despite the fact that we spend around, let's say around more than $60 per capita, even countries that are spending far lower are having lower under 5 mortality rate. It shows in terms of how efficient we are with the spending. So, and you see how some of these happen. Next slide. So, again, more health for any. What are the sources of inefficiency in the health sector? All of us know, but just to quickly remind ourselves. Number one, in terms of even how we organize our health system, we are not very efficient. When Sati becomes a member of House of Rep, when chiefs become members of House of Assembly, and they want to show the community that they are working, they will put one primary health care. And you have proliferation of primary health care, that some of them, they will be housing goats. And again, do you know what that is even more important? We proliferate those facilities. One, it is not even where they are needed. Secondly, we are not producing or providing other inputs of health, like health workers. Even the few health workers you now have, you now spread them over, and none of the facility will be able to operate 24 hours. And the women here know that, the deliveries at times come at night. And in the remote village, because we did not organize our health system well, nobody to attend to our deliveries and orders. And again, not only that, even the commodities, there are a lot of issues. I've seen facilities where there are a lot of expiries of drugs for a number of reasons. But probably the worst one is in the area of human resource for health. If you look at a typical health facility, a typical state, they spend 80% of their health budget on human resource for health. And that's where the biggest inefficiency comes. And I'll give you some example. I don't know who can see. I took this snapshot or screenshot of this day newspaper of sometimes in 2018. Can somebody read this for me? Okay, did you see that? Someone, okay, maybe I'll give you whatever to read it.
Sokoto uncovers 6,000 ghost health workers.
So when you hear this, what comes to your mind? What question would you like to ask? Ma, okay. Total population, right? Yes. Yeah, you see, you are too intelligent, man. So that's exactly the question. 6,000 out of how many? 6,000 out of 13,000. Very, very serious. Okay, we are coming there. We are coming there. Do you know the person that made this pronouncement? Do you want to know who made this pronouncement? The executive governor of the state himself. But people should be more interested in what happened after. That's where we are coming to accountability. Again, look at, this is another state. I won't mention name of the states here. Please, I won't. Sorry, okay, I should be transparent, right? Okay. So look at how health personnel budget increased from just 1 billion to 7 billion within the period of 2004 and 2012. And when we actually mined this data, when we analyzed it, a lot of things were actually, we're thinking of a lot of things. Is it that they recruited a lot of health workers during the period, or they adopted a new salary scale? But do you know what? They didn't adopt any new salary scale. What the salary change was marginal. But the most disturbing aspect was that there was an embargo on recruitment during this period. Okay, that's the question I asked when we saw it. And it's not in only that state. A lot of things are happening in many states like that. So we're so worried that how come multiple fold increase in the personnel expenditure, yet there was an embargo on recruitment. You are not recruiting. And during that period, the density of workforce in terms of number of midwives actually reduced, to the extent that in some hospitals, they were closing down some wards because they didn't have personnel to work. So we're so curious. What is going on? Then we started asking questions. We went to the permanent secretary, everybody, and all of us, they were claiming ignorant that they were saying this for the first time. And somebody just called us. You have to be very careful. Many people are involved in these things. You are still young. Then we said, okay, we know what we're going to do. We're going to escalate it to the executive governor of the state. And the fellow we told laughed at us. I said, why did you laugh? He said, the incumbent executive governor was the commissioner of finance when this thing was happening. And this is just to tell you how complex the work of accountability could be at times. Okay, next slide. So we'll quickly go look at some existing framework in terms of if we want to raise the accountability bar. What are the most important elements we look at? Next slide, please. So I won't spend too much time on this, but there are a number of them, but I will try as much as possible to emphasize on this one, which is looking at 3 important areas. One, you have to raise this transparency. People have to know. You can't hold people accountable for what you don't know. It's because we did the analysis of expenditure, spending on personnel. That was why we were able to ask questions. Before then, many people didn't even know whether the amount of money spent on personnel is increasing or not. So transparency is the number 1. Number 2, then you have to ask questions, and that try as much as possible to watch, to follow, to ensure that it's a change. The good thing about the question that I use as an example, when the new executive governor came, we presented the paper again. He did staff auditing, and the governor took a lot of steps. They were able to recover a lot of resources, and they used, the savings to engage additional staff and were reviewed. So next slide, Let's move on. Now, let's move on. Yes, so I'm just going to the accountability framework that the HSRC now put in place. I show some of those framework to help us understand the basis for the framework. Next slide. So what is new? Because in development world, we use framework a lot. We use accountability framework a lot. So what is new in this accountability framework? Number 1, we are looking at all health financing mechanisms, whether government money, government discretionary spending, government earmarked money, donor money, because the donors are not absorbed of this issue of accountability as well. All of us, we are together in it. and then even health insurance financing mechanism. We look at everything holistically. Then it is action oriented, because if you look at most of what people say they are doing as accountability, it's only one aspect of accountability. They want to increase the transparency. They develop scorecard, for instance. The question is, and so what? What happened after the scorecard? Then two, we want to do combination of typologies. You know, I talk about political accountability, bureaucratic, financial, and everything. We want to bring everything together, and the multi-stakeholders engagement. So once the policymakers, the citizen, the legislature, the civil society, and the media. I don't know whether the media is represented here. Is anybody representing the media here? Okay, thank you very much. You have a very important role to play. And it's not only at the national level and subnational level. And then the framework that we develop is meant to be adapted by different program areas. It's just a guide in terms of if you want for us, and that is why we are going to adapt this for the basic care provision fund. Then we are looking at it to be technology enabled. A situation, our vision is that our accountability framework will get to a stage where on your phone, you can click on something to know how much is spent by government of Kebbi on health, on family planning, versus what is released, what is spent, and what this money is. We are not there yet, but in terms of what is new, this is how it is envisioned. Next, we'll be looking at the theory of change in terms of what gives us the impression that if we do this, it will lead to this and get us the, before then, this is the process we went through. We did the desk review. We look at what is happening elsewhere. We look at our health financing landscape. We look at accountability framework of others that have they put in place. Then we design something. And then we went through a series of stakeholders engagement. My very good friend Anu is there. We did a lot of things together. She was always disturbing, where are we with this accountability framework and all those stuff like that. And then further review, and we hope that we'll validate and we'll continue to use. Next slide. Next slide, please. So in terms of our theory of change. So again, it's very, very simple. Number one is that to know, to act, and to change. We believe that if we know about a lot of things, about the rules, about the volume, about the process, about the input, about the output, about the impact, and we act based on this information, we are going to change something. It's as simple as that. Next slide. So in terms of transparency, to know, what exactly do we know, should we know, if we want to raise the accountability bar? Number one, whether basic care provision fund, whether spending on family planning, there's a cancer health fund now. I hope we know about it. They started disbursing money. Somebody said, sending a text message to me that each patient will be entitled to like 5 million naira or something like that in cancer health fund. Cancers could be very expensive. So, do we know the rules guiding whatever funding that we have? Basic care provision fund, if we want to hold MOC, want to hold NHIS accountable, do we have a good understanding of even the operational guidelines and how it should run in the first instance? Do we have information about the input, what amount has been disbursed, who has received what, where is the money going, and what is the money by? What are the processes involved? The output, which facility has received the money, for instance? And again, outcome, how many people are actually coming to the facility? I will show you some interesting data in terms of from facility. We have started seeing improve outcome in some of the facilities. Who needs to know? Citizens need to know, the policymakers, the lawmakers, the media, and the social, and every other CSOs, and every other thing that you think you know. How do we know? Somebody needs to collect the information. Somebody needs to process it. Somebody needs to design in such a way that is very, very simple for us to relate with, what they call data visualization. A lot of people use scorecards or use infographics and other things, such a way to, and disseminate who is getting it. So to know. Next slide. Perhaps this is the most difficult aspect of it, to act. Who is acting on those information? And when I'm talking about this, I remember a good erudite scholar. Let me ask, how many of us have read 7 Habits of Highly Effective People? The other time I asked the question, somebody says, I've seen it before. Yeah, I know you have read it. Who else has read the book? Please, if you're not going to read any book in the next 5 years, you must read that book. For people to be effective, it's like the Bible or the Quran and whatever of it. It's written by Stephen Covey. And he said, to know and not to do is really not to know. If we know something and we don't act based on that knowledge, you are not different from somebody that does not know. If we know that somebody is sleeping, I will not tap him. If you know that somebody is sleeping, I did not tap him. Okay, I will tap. Okay, so I'm talking about to act, which is very, very important. Let me give you an example. When Okonjo-Iweala became the Minister of Finance, she was so disturbed that there are a lot of wastages at the local government level. And she said, do you know what I'm going to do? I'm going to publish all the allocation going to the local government every month. And when you open the pages of the paper on a monthly basis, you will see Gabi local government, so a month. So this is local, so a month. And they did it for several years and nobody did anything with it. And they stopped. So it's not enough for us to know, we must use that information for decision making. And in terms of using that information, quite a number of things are important. You have to engage first. Because at times, the information you are able to gather, the people that will make necessary changes, perhaps they are not aware of that information. And let me give you an example. When I engaged governor, my team, Frances is there. In 2018, or I think Juliana was there as well. When we engaged Governor Wike of Rivers State, because we are implementing a project, and we did the analysis of our HIV/AIDS and financing and all the stuff, and the problems the HIV team they were having. And when we presented to Governor Wike, and before I did that, I made sure I said a lot of good things about what he was doing in the state, so that I was able to get the audience. And when I was saying about good things, he now sat down very well. I was now looking at me. And when I now finished, he said, thank you very much, Doc. He now turned to his commissioner for health. He said, Honorable Commissioner, how come I'm getting all this information from an outsider? So the HIV situation is so bad in my state and I'm not aware of it. Mr. Commissioner, you are the one spreading HIV in Rivers State. And you agree with me that we could go Governor Wike can say that kind of thing. He actually said it. And the worst case scenario, as bad as the HIV situation was, the SACA, the state agency, did not even have an office space. He now turned to the SSG, said, SSG, how come there's a huge problem like this? And the organization saddled with responsibility does not even have office space. They don't say, Your Excellency, sir, I just wrote a memo last month. I wanted to present to you and everything. Say, I give you 2 days, go and find them an office space. Engagement is very important because it's not in all cases that the people that were engaging actually, because we have the impression they know, they do not just want to do something. After engagement, when I'm talking about what we need to do, is we ask questions. We hold people accountable by asking questions. Why is this? What should we do about it? And again, I advocate as much as possible. Then in terms of who should know, the citizen, the political, lawmaker, and media, all of us have roles to play. We have to sensitize people so that they know when they are equipped with information. I'm saying this because on basic care provision for a lot of us will be pushing out scorecards, scorecard on this, scorecard on that. And the question is that who is doing what with those scorecard? And how do we do it? There are a lot of fora for engagement. Of course, we have to know that engaging the policymakers at times could be very, very difficult. We have to use the right medium, the right people to get to them and do that. So town hall meeting, policy dialogue. But more importantly now, we are in the electioneering period where the political class are asking for our votes. Do we ask them? One of the candidates 2 days ago, he said, I will make health free for everybody. Is the enemy asking questions? Is everybody asking questions that how are you going to make health free for everybody? What is your key policy trust? Where would the money come from? How do you build on the existing policy stuff? And the last aspect of the theory of change is to change something. Next slide. And again, we have to identify specifically what change do we want to see. It could be in terms of health indices of optimal funding, changes in efficiency and conformity with the established rule. Again, who needs to change things? Policymakers, the providers, and depending on what the change we want to see. And how do we get there? Can we apply rewards and sanctions? And peer comparison. One thing that I know our governors are sensitive to, they are sensitive to peer comparison. So we develop a scorecard on the release of equity fund, and we get to the Nigerian Governors Forum Secretariat and presented to the governors. And when one of the executives of health insurance was telling me that the governor came back and said, the governor sent for him. I said, how come I'm having red here, despite the support I'm giving to you? I said, Your Excellency, you are giving the support, but you are here to release the equity fund. How much is the money? Okay, go and get the half of it. So we have to know what works and what doesn't. So next slide, we're getting there gradually. So based on this theory of change, we now develop the matrix. So the matrix look at different aspects in terms of what indicators are we looking at across government discretionary financing, the earmark funding, health insurance money, and others. So let's move on. Okay, so in terms of government discretionary money is the one that amount of money you allocate can vary. You can put make a health budget to be 6% this year, 7%, and you can allocate it which area of preference. So apologies, this is not showing very well. So we have a number of indicators which we are looking at in terms of health budget as a percentage of government. Most of those indicators that the doc presented earlier on are here. And then we'll look at what is the target, what is the actual. But more importantly is the action. What should the lawmaker do? What do the executive do and CSO do? Later on, we'll give some, when some of the partners are making presentation, they will give some specific examples of how they've used this. Next slide. So in terms of earmarked money, don't forget, because all of us, we are so concerned about basic care provision fund. We have forgotten that there are other earmarked funds in the health sector. At the state level, states are supposed to be spending 1% of their equity, of their state equity fund, just like the federal level, as the equity fund. How many of the states are doing it? Last time I checked, they are not more than 6 or thereabouts. So, as part of the health financing accountability framework, we want to know whether they have allocated this money, what proportion have they released, and what are they using it for. Again, the basic care provision fund, in terms of the law says not less than 1% of the consolidated revenue. And I'm very happy that our lawmakers are trying to actually increase that up to 2%. But how much is released, how much is spent? There are periods where there are a lot of issues with releases of these funds. So what do we need to do and what do we need to do about it? Next slide. Again, so in terms of the health insurance level, in terms of health insurance, so all of us are aware that at the state level, there is still social health insurance scheme, where states are expected to have their health insurance scheme, release equity fund, enroll people. But if you look at the state health insurance scheme, probably not the fault of those people managing things. They have heavily focused on the basic care provision fund, money coming from the federal government, and then the formal sector. And they were not actually making much progress in terms of the informal sector. People that actually need health insurance more are the one not getting it. And I was speaking with a colleague that came to Abuja, one of the years of the store. He was very happy that he's making progress. He has enrolled 36,000 on basic care provision fund, 18,000 formal sector. And when I asked about what are the informal sector, the poor and the vulnerable and others, he said, okay, we are around 25 or thereabouts. And those are the people that actually need this health insurance more. Next slide. Again, in terms of national health insurance scheme, you know, the NHIS, I believe there's some people from NHIS. About 2 weeks ago, NHIS had a parley with the partners to look at the updates in the implementation of NHIS. And in fairness to Professor Sambo, he has done a good job in terms of institutional repositioning. It was not what NHIS was before that it is today. And in terms of putting the ICT, check and balances and everything. But the question I asked and what I told Prof, what is going to be the new frontier? When you call us next year to tell us about updates, we are more interested in how we have increased the enrollment rates in terms of what proportion of Nigerians are actually having health insurance, how many of them are poor and vulnerable, what's the proportion of women, because we don't want to leave our women behind as well, and children, and the vulnerable population. So we have a set of indicators that look at different dimensions. And then in terms of efficiency as well. Next slide. Again, external funding. Our accountability framework should expand to external funding as well, because our external funding is not immune to inefficiency. And in other countries, there is a strong coordination of external financing. They actually use the principle of aid effectiveness as much as possible. Again, do we have a very strong coordination, donor coordination structure? We used to have at the national level, I doubt if it still exists, that bring donors together and align the financing to the priority of the country. Not donors saying, I want to do this. State, come and align with that stuff. No, shouldn't be. We should know our priorities and try as much as possible to align. It's actually happening in other countries. Again, availability of data. And this is very important for donor financing. And when we are trying to raise accountability bar, this is what we should try as much as possible to do. Our donors and partners, they position themselves as the watchdog. Is that not? But at the same time, it is easier to get government financial data than to get the donor financial data. So who is holding who accountable? Are we together? Are we together? It's a lot easier to get federal, state government spending than to get to the financial books of donor and partners. We shouldn't be. We should raise the accountability bar as much as possible. Somebody say, I'm shaking the table, right? Okay. And then other parameters are as well. And again, as much as possible, our donor funding, partner funding should not be replacing government money. It should not be fungible. There are a lot of areas where donors spend a lot of money. It's becoming very difficult to ask government to spend money in that area because government think that's the domain of the donor now. Let my government use the money for road. Let's use money from BMGF to buy family planning commodities and all those. We shouldn't be. Next slide. Again, so it's not only about how much we have spent in terms of results. This multi-sectorial accountability arrangement should be looking at the results, the progress that we are making in terms of what the proportion of facilities having necessary commodity. And then in terms of impact, maternal mortality under 5 mortality ratio. Whenever they release NDHS, I will expect people to come together, NDHS, National Demography and Health Survey, and come together and say, how has Nigeria performed? How has Nigeria performed, given put side by side investment, the money that we have invested on it? So this is part of what we need to do in terms of the result as well. So let me quickly, next slide. So in terms of even the basic care provision fund that we started implementing. So this is from a project that we implement in Nasarawa State to look at facility utilization, because ordinarily, in this part of the world, because of financial barrier, many people are not actually using health facility. Am I correct? A measure of facility, are we together? A measure of facility utilization is what they call consultation per person per year, which means if we have 100 people in the community, how many times do they actually attend facility? That one person will attend one facility per year. You'll be surprised that in Nigeria, on average, consultation per person per year is less than 1. Meaning if you have 100 people in a community, in the whole year, number of facility utilization will not be up to 100. Very, very low. And what is the benchmark if we must achieve universal health coverage? The benchmark on average says at least 4 consultations per person per year. I should be able to go to a facility at least once a quarter to check, to do some tests, to do this and all those stuff. But because of financial barrier, I'm not able to go. So what is now happening as a result of implementation of some of these basic care provision fund and equity fund? Now, so in that particular, each of these represent a facility. Now, so in this facility, there is a partner that actually brought money to buy health insurance for some people. They bought health insurance package for people, and they introduced community engagement process and accountability mechanism. And this particular facility, for example, facility utilization was as high as 4.8 or 5 consultations per person per year. Don't forget, among those people that have no health insurance at all, it was as low as 0.7 in that particular facility. And again, for those people that are on basic care provision fund is good here, 3.5 is up. For the equity fund is 2.5. But across those facilities, none of those facilities where basic care provision fund utilization was up to the one that was implemented by that project. Of course, there is improvements because of implementation, but it is not where we are supposed to go. So if we increase accountability, and again, I was told that it's not like that in some states. Even with basic care provision fund, I was told utilization is not different from those that are not on any enrollment at all. I don't have evidence for that, but I was told. Okay, so next slide. I'm getting there gradually. So we have seen some results as a result of implementation of accountability framework. Later on, our colleague from GHI project, Lisdell, will tell us that at the national level, because of effort of some partners, they did an analysis and they discovered that in terms of health security, NAS represent National Action Plan on Health Security. Initially, it's a multi-sectorial thing. There's a lot of organizations, even Ministry of Agri is part of National Action Plan. But before, those ones were not getting allocation. So there was an analysis, there was engagement, they were now getting the allocation. In Kano State, because of analysis, engagement, there's a creation of budget line for health security and they are getting the funds. The same thing applies to Lagos State. So this is just an example. Later on, we'll get the details of some of these results. So next slide. So in conclusion, and some of us are happy that I'm concluding because. So in conclusion, I think raising the accountability bar is in qua non of achieving development. We cannot make progress if we are not raising the accountability bar. That is very, very important. And mobilizing more money for health and achieving more health for money become more feasible if we raise the accountability bar. And existing accountability bar is only focusing on telling us about this is happening, that's not happening. We are not actually focusing on to act and to change something as well. The HSR accountability framework is a template that is being adapted. This template for adaptation into different program area, family planning, basic care provision for malaria and others. And again, there is need to adapt it to more program areas. But finally, effective deployment of accountability framework requires institutional capacity. We have to continue to train our capacity. It requires strong leadership. If we must come to equity, we have to come with equal hand. It's not, with clean hand. It's not enough to say I'm implementing accountability framework. We have to demonstrate, we ourselves have to be accountable in what we do so that people will take us seriously that, okay, you are seriously talking about issue. And again, it's unfortunate we don't have the National Orientation Agency here. We need serious value reorientation. I was telling somebody that at National Orientation Agency, what exactly do they do? Because there are a lot of things that require our reorientation. Orientation around equity, orientation around accountability as well, as much as possible. So because I don't talk too much, I would like to stop here and thank you very much for listening to the presentation. So again, because this is democracy, we ask our chair and everything. Should we quickly take our tea because it's getting cold when we come back? We'll now take questions and move on. It's a democracy, but it will start from the others. Okay, doctor said he will forget. But I think there's a minority opinion, right? Should we go for tea break now, come back and have discussion? Okay, are we sure? It's only one person that is answering. Should we go for tea break now? Or we take the question and answer? Okay, Secretariat, how many minutes do you have to start with the tea ready? This is 12 noon, to be. Is it ready? Okay. Okay. Yeah, how many minutes do you have for tea break? 10, 15 minutes because our time. Should we do like walking tea break? Our time is fast spent. Okay, please let's grab our tea and the next 10 minutes we'll continue. Thank you very much. So our virtual participant, please try as much as possible. I wish you can invite you to come and take tea with us, but please try as much as possible to put your questions and contribution. And okay, please help me to address some of those questions, please, so that yeah.
On universal health coverage, especially generally in Nigeria and especially in FCT, I'm just concerned about the uptake by informal sector. That is private businesses and artisans and the rest of it. And we know that most of the uptakes are in the formal sector, which form bulk of what we have right now. And the informal sector is an area that the percentage uptake is so low, so low. So I want to find out from him if there are any strategies in place right now to increase the uptake at the informal sector part. And then secondly, I would want to know if there are also data that can really give us the numbers of that of the formal and informal sector today in Nigeria. Because some of us will need such to work, to carry out our own scope of work that we have in that area of universal health coverage. Thank you very much.
Thank you very much, sir. I would like to also welcome our online or virtual participants. I'm sorry for not doing that earlier. So is there, and we'll come back to the questions from the online participant, please. But let's take the one from within the all first. Okay.
Okay, so thank you very much. My name is Ali Boala. I work with Options Nigeria. My question is to the presenter from the Federal Ministry of Health. even though he presented a lot of data, but I must confess that I was not able to see those figures very well. So I just wanted to find out or ask a question about government's ability to bridge the gap that is being filled by external donors, so to say, because I know that there's a lot of investment into health by donors. And when you, and for example, in some states, when you work in the states, they tell you that most of their health budget or most of the spendings on health or investments in health a lot of investment come from the donors. And for me, I feel that for us to be able to work towards achieving universal health coverage, we have to be able to actually reduce dependency on external sources of funding. So I was trying to find out if we have any statistics on this, and if you'll be able to tell us what efforts or how far government is going towards reducing dependency on external funding, looking at the funding landscape. Thank you.
Thank you. That is noted. Please, any other question from within? Do we have the online one? Okay, while we collect that from the online participants, I will hand over the mic to I wouldn't know if the first presentation was, the two questions asked were directed to the first presenter, which from the Federal Ministry of Health. I wouldn't know if the NHIS would be willing to respond to those questions.
Thank you. So, if you could ask the question again, let me. Informal sector. All right, fine. You wanted data on our informal sector uptake. Okay. We don't have much data, but even the data we have will not be useful to you. Let's say the truth. Secondly, when you talk about informal sector penetration, you know that because they are heterogeneous, and even if you see our tax in Nigeria, we can't even tax them. It's very difficult to gather them and do any reasonable thing with them. And even when you do, we really don't have a clear distinction between what is vulnerable and what is informal sector. So even the informal sector people want free service. And what we are working on is, because we have an established formal sector pool, we have this gift ship program, which the presenter said was 15,000 naira. So the idea is to push it out to Nigerians and see how many people will be interested in taking, which gives you the same benefits as the people in the formal. I think it's affordable because it's just over 1,000 naira a month. But a lot of sensitization has to go into. And secondly, we have the state health insurance agencies. They also, at that level, also should push their own. And we're working in partnership with them to see what strategies we can develop to bring as much of the informal sector as we can into the system. I hope that answers some of your questions, not all. Thank you.
Thank you very much. I wouldn't know if the second question has been captured. Was it? On the government ability to fill the gap by donors.
That's above my pay grade, please. Let Ministry of Health answer that one.
Okay. All right. Any other question within? Sorry, the online participants. Let me get the questions. Sorry, I'm coming. Okay, so the second question is the ability of the government to fill the gap that's currently filled by the donors.
Thank you very much. For the health sector generally. Again, if you say what are the gaps that, what are they doing to fill in the gaps and what are the partners doing? It is also important to note that the partners are here because the health sector exists, and it has also created jobs for the health, for the partners itself. So you can imagine if you fill in all the gaps and the partners no longer have anywhere to go to, they will become jobless. So they're also doing their own part of their own bits, and then the government is also doing its own bits. However, that was in the lighter mood anyway. But seriously, we need an increase in financing of the health sector. The 1% consolidated revenue from the Basic Healthcare Provision Fund is grossly inadequate, considering the services that are required by the population of Nigeria. It means only 1 million Nigerians have actually benefited from the Basic Healthcare Provision Fund out of about 80 million Nigerians that are poor. But that is why, again, we are here to put our heads together and see how we can increase funding in the health sector. Thank you.
Thank you very much, Dr. Kala. So I will just read out some of the questions that were harvested online, okay? Before then,
Good afternoon, all. My name is Aminu Salis Adam. I just want to know, when was this data generated? Because I have little confusion about it. I want to know the period.
thank you. Dr. Jafar, do you want to respond to that? Okay.
All right, thank you. Actually, my question goes to the two presenters. I would have loved to see maybe in terms of the presentation from Federal Ministry of Health, in terms of how we've been able to link the financing to health outcomes and health indices, because when we make investment, the investment is not just about the data, it's about how does it translate to value, how does it translate into delivery of care. So now with this projection, it would have been good if we can have that alignment in terms of the investment over the years, and have we moved in terms of our health indices? Are we getting better? Maternal mortality rate, child mortality, and all those other key indices. So when we are talking about investment, we are seeing the outcome in impactful manner. That's one. So coming from that perspective, we're talking about accountability framework, now linking it to what Dr. Gafar's presentation. He highlighted the different types of accountability: political, social, bureaucratic, and the rest performance. Now, how do we come in terms of quality of care, accountability for quality of care? Because health sector, it's measured in terms of, we have both normal layman's accountability, we have the professional account. But in terms of basic care provision, I know that the NHI and the NPSCDA and the NHI has their framework in terms of measuring. But in terms of civil society, what are we actually going to be looking at that will help us identify those quality of care to ensure that the money is actually not just being spent, but it's actually translating into the actual value of care that we meant to see. Thank you.
All right, thank you very much. I hope the presenters are taking notes. Please let me just run through the questions from the online. Peter Oshazi said, another perspective of accountability under the Basic Health Provision Fund is the enrollee satisfaction rate, not just service utilization rate. Now, the basic healthcare provision fund targets 80% enrollee satisfaction. How do we track this from time to time? That's the first question. Another question from Harriet Edumo says, there is serious for us at the health sector to have good understanding of the budgeting, of the budgeting process of the federal and state where we work, especially things like operationalization of the earmarked fund for health, linking or strategy health plan with budget. Sorry, that was just a comment. Harriet Edumon, okay. I wouldn't know. From our journey so far, this from Kenneth Adagba, from our journey so far, what is the major challenge with strengthening accountability of healthcare financing as we move towards universal based health coverage in Nigeria? Then from Tafa Kwagba, it says the Basic Healthcare Provision Fund has reduced the financial burden from out-of-pocket expenses on health for households of the poor and the vulnerable. But at the moment, most states have not started releasing the 1% consolidated fund as equity to the SSHIA. So what can be done to ensure that states fulfill their obligations of releasing the equity fund? Then the next question is from Samson Ezekiel. He said, does Nigeria health system need more money? I asked this question, which is pertinent now as we are talking about accountability. What is the role of reform? What is the corruption? What of the corruption in the system? That's from Professor Omojuke. Sorry, the name is there.
So thank you very much for the questions from the participant and an online participant as well. I think there are a lot of very, very important questions there. There are some that will be answered during the course of this workshop, like a question on challenges of raising the accountability bar. Before we finish today, we are going to have a group discussion, which will be specifically looking at that. So there's a question on the satisfaction of the basic care provision for enrollee. So let's wait till tomorrow when we listen to the basic care provision gateway, NHIS and others. But I know that the standard way for gauging satisfaction is to do a satisfaction survey and other measures as well. So let's listen to them tomorrow, then we can discuss that further. So question on when this data was collected. It was collected last year, but let me quickly say that it was actually 6 months data that was prorated to calculate consultation per person per year. Strategy for the informal sector at the NHIS has answered that. Reduction of the dependency rate. The Federal Ministry of Health, I think they put in place health financing policy and strategy. And part of the policy and strategy is to raise domestic resources to ensure that we're able to reduce dependency rate. But let me quickly say that in terms of funding of health, donor funding does not account for more than 10% of total health expenditure. But in some critical public health aspects, like malaria, like TB and HIV/AIDS, actually the proportion is very, very high. It could be as high as 17%. So if we are talking about dependency ratio, in those who are public health funding, I think it's very, very huge. Domestic resource, mobilizing domestic resource and raising accountability for domestic financing is very important, including family planning as well. So we have to, because our time is fast spent, we are behind schedule. So we would like to continue with presentations, and we thank our online participants for asking their questions. Some of them will have loved to ask their question directly instead of putting in chat box, but so that we manage the audio system effectively. We apologize for that. So we'll be taking presentation from partners here present, those that are implementing some kinds of accountability initiatives. We have Mama Ye here, we have African Health Budget Network, we have Lisa. Our budget is not yet here. We have Cadma, right? Okay, so can we start with Mama Ye? Ali Boala. my veteran MIE specialist. So can we put Ali's presentation of the MMIA, please? Okay, Ali, over to you. So you have 15 minutes, please, so that I'll manage.
Okay, thank you. Okay, so before the presentation comes up, maybe just by way of introduction, E4A, evidence for action, that's what it means. E4A, MAMA is actually a Bill and Melinda Gates Foundation funded project implemented by Options in Nigeria. And the project acts as a catalyst, as a catalyst for action, enabling government, civil society, the media, and other partners to be able to strategically use evidence to generate political engagement, to generate political commitment, and also be able to strengthen accountability, as well as improve planning and decision-making at all levels. And over the years that this project has been implemented in Nigeria, next slide, we've been able to bring together what we call state-led accountability mechanisms, which comprise of multi-stakeholders, government, CSO, media, and health practitioners, to be able to use evidence to support advocacy for maternal and newborn health issues. And these coalitions, or these slums, as we call them, work with the government to generate the evidence and develop advocacy materials. They develop scorecards, and they use those things to advocate to government and other stakeholders to address identified gaps that have to do with maternal and newborn health, all with a view to improving health services for women and their newborns. Next slide. Now, specifically for BHCPF, what the project has done is actually to empower these slums to use the evidence, to generate first and use the evidence to track the progress of BHCPF implementation in the states where we work, using the scorecards. And this helps the coalitions or the slums to be able to hold government accountable, and for them to be able to keep to their commitments to improve the implementation of BHCPF. And we do this by building their capacity, by providing them technical assistance in terms of training, mentoring, and development of scorecard tools that they use to develop those scorecards. And we also strengthen their capacity to be able to use the evidence to develop appropriate advocacy messages and asks that they now target their the stakeholders to make conduct their advocacy. Part of what they do here is also they do stakeholder and mapping analysis to be able to identify, okay, who are those people that matters that they could actually target with those advocacies. So it shows that they will be sure that those areas where there have been evidence shows that there are gaps are actually addressed and that commitments are made and fulfilled. Next slide. So this is just a screenshot of some of the scorecards we use. So we use what they call the traffic lights. And this is basic healthcare provision scorecard for Niger State, April to December 2021. Next slide. So this is the other page. These are the indicators. So we have benchmarks, we have the indicators, we have the scores, and then we have a page for the advocacy asks that have been developed as well at the back of the scorecard based on the results in the scorecard. Next slide. Now, these scorecards measure a lot of indicators, but broadly across 3 areas. They look at governance. Governance is actually about the structure, the administration, and the management of BHCPF implementation. These are just, in that section, I think we have about 8 indicators. And these 3 are just examples of those indicators. And then there are service delivery indicators, about between 12 and 13 of them. These are just some few of them. And then community participation component, we also have some indicators. This is actually about how the communities engage with the different implementers of the basic healthcare provision in order to ensure that they also participate actively and also make their inputs to ensure that the implementation is done successfully. Next slide. Now, we've been able to record some results, particularly in Bauchi and Niger. And just to say that we actually work in 3 states, Bauchi, Niger, and Lagos State. For Lagos, Lagos hasn't done anything tremendous about BHCPF implementation yet. So we have not been able to work with them yet we have not started working with them in terms of developing BHCPF scorecard, but in Bauchi and Lagos, they have both developed 2 scorecards each between from the last quarter of 2020 up to the end of 2021. Each of the states have developed 2 scorecards each. And in both of these states, the government have accepted these scorecards and are using them to track the progress of implementation. And the coalition, the slums continue to use the scorecards to conduct their advocacy and ensure that they are able to hold government accountable on their commitments. Some of the results we also got is that in Niger, evidence from the scorecard actually hastened the recruitment of more midwives and nurses for the focal PSCs as a way of improving services and also increasing access to services. In Bauchi State, the evidence from the scorecard showed low uptake of services. A bottleneck analysis of what the problems was done, and it was discovered that in collaboration with the community level participation, it was discovered that there was low sensitization, there was low awareness, about the availability of basic health care provision services. And some of the actions taken was that government now increase some funding for awareness creation to ensure that people are aware and they access the services. Next slide. So in working on this, we've actually been able to identify things that we feel actually can be seen as risks to the successful implementation of this and also for accountability purposes of a reliance on implementing partners for training and supportive supervision. Like in these 2 states, what we've gathered is that they don't have enough funding for training of the facility staff and the project managers, and also for supervision of these facilities. And these are things that are very key if we really want to ensure that there's improved service provision and accountability. Lack of engagement of the slums in BHCPF activities like training and supervision by government. So these slums work with since they are multi-stakeholder, they have the government, they work with the government. However, when it comes to some activities, they are excluded, and they feel that for them to really have a good grasp of what is happening so that they'll be able to gather data that will help them to do proper advocacy and also be able to advise government on areas that they need to improve. There's need for them to be involved. Weak financial management and accountability systems leading to poor service delivery is a risk. Poor data management is also seen as a risk. For example, the first scorecards the slums developed in both of the states, there was no data for service delivery, and so like if you look at the scorecard, one of the samples of the scorecard I showed, the indicators on service delivery were blank. There was no data. And all that was as a result of, okay, we have not reported, the facilities have not reported, this one have not reported, and all that. Lack of political commitments for the release of funds. One of the indicators on the scorecard measures the timeliness of release of funds to the facilities. And this is also seen as a risk. If the funds are not reaching the facilities at the right time, then we don't expect to have good services from those facilities. Inadequate human resources to implement the program is also a big risk. Political interference as higher level of government is also seen as a risk. Next slide. Well, working with the slums, we've had a lot of lessons learned. Actually, involving the government in the slums helped the organizations or helped the program because they are able to provide the data that is needed in developing the scorecards to track program implementation. And the availability of these scorecards have also enabled the coalitions to provide constructive feedback to the stakeholders and the policymakers. And the government also finds it useful in tracking the implementation of the program. And it also helps in uptake of the evidence. I know one of the issues we've been having, people we usually have, like when it comes to working with government, is the uptake of the evidence. Now, since they are involved, I mean, it makes things easy because they are part of the process, they know where the data is coming from, they know the process that went through to be able to generate this evidence. So they find it easy to uptake this evidence and use it for decision making. Next slide. Okay, so that's it. Thank you very much.
So thank you very much, Ali, for that great sustained presentation. Please note your questions and contributions, including our online participants. Please note your questions so that after the presentation from our partners, we'll have question and answer section. So we'll quickly take presentation from African Health Budget Network. So let's appreciate that, please, from African Health Budget.
Thank you, Dr. Gafar. Good afternoon once again, everyone. I'll be taking us through our work and experience working with MPHCDA Basic Healthcare Provision Fund Gateway. Next slide, please. Next, please. Okay, so like I said, I'll be taking us through AHBN's work and experience working on the MPHCDA Basic Healthcare Provision Fund Gateway Accountability Performance Scorecard. So in 2019 and 2020, AHBN developed 2 performance scorecards on the Basic Healthcare Provision Fund MPHCDA Gateway. And it was primarily to promote accountability and transparency of Basic Healthcare Provision Fund in Nigeria. So the purpose of this scorecard is to actually showcase the readiness of the states in terms of the disbursement and utilization of the funds for the gateway. And then this scorecard was developed in order to be reviewed on a quarterly basis and then presented to stakeholders with the aim of improving performance and transparency of funds utilization. Next slide. So here I'm going to show us what the scorecard looks like. Next. So this is actually the cover page of the scorecard, and it covered the period January to December 2020 across all the 37 states in Nigeria. Next. So here, it shows that, so this is also part of the scorecard, and then it shows that there's a 12.7 billion basic healthcare provision fund disbursement as at 17th September 2020, with the breakdown of 6.35 billion, representing 50% of that allocation. And then we have 5.715 billion, representing 45% allocation to NHIS. And then we have 635 million naira, representing 5% of the emergency and medical treatment gateway. And then, like I said earlier, the scorecard was reviewed on a quarterly basis and then being presented to stakeholders. And the overall objective of it is just to ensure that the 37 states in Nigeria, you can actually see the readiness for that gateway towards BHCPF. Next slide, please. So here, I don't know if we can see this very clearly. Okay, so I'm sorry about this, but I'll just walk us through it. So here we can see that we have 37 states, including FCT. And then we have 5 indicators over at the top here. We have the TSA account created. We have the gateway fund disbursed by MPHCDA. And then we have the signatories activated. And then we also have facility baseline assessment conducted, and then the training itself conducted. And then here we have the scoring sheet. Is this clear? Okay, so here over the scoring sheet, for example, where we have the indicator that says TSA created, and then we come here and see what does this tell us within that period of time which this scorecard was developed. It says that if it's green, that means the TSA numbers have been provided to the SPHCDA board. And then if it's amber in color, that means TSA processed Central Bank of Nigeria. And then if it's red, that means the TSAs are not created as at that time. And we can see that if you look all through the 37 states, it shows that they were all green as at that period. So which means that the TSA numbers have been provided to the SPHCDA boards. Then, looking also at the second indicator, we have the gateway funds disbursed by MPHCDA. And then we also have the color coding, which says disbursed fund cited by the online banking platform. It's yellow if it's disbursed but has not been cited on the online banking platform. And then it's red if the funds have not been disbursed. And we can also see that looking at that second indicator on the scorecard as at that period, December 2020, it shows that all the states were green in color, which means that it's been disbursed, the funds have been disbursed and cited by the online banking platforms. Then moving into the third indicator, which says signatories activated. So it's also very similar. We have just one state that had yellow color, that had red color, which states that the signatories' names have not been submitted to CBN as at then. So it's very similar to also the fourth indicator and then the fifth indicator. So this scorecard, when it's completed at a glance, it gives you an overall overview of what is happening in all the states with regarding the MPHCDA gateway disbursement and the use. Please, next slide. Okay, so here as well. So what this section is actually telling us is that we have the states, then we have the numbers of participating facilities, and then so this column actually shows us the total number of facilities participating in each state. So that's why we have like Abia 292, Zamfara 147, among others. And then here we have the proportion of facilities that were authorized to receive funds as at December 2022. And this is just a proportion. For example, let me just speak to Abia State. Abia State says 237. So that means 237 facilities out of a total of 295 facilities that were participating at that time had received their funds, which represent about 81%. So we can also see the total percentage for each state at a glance. And then also we have here, overall here, there's a statement here. I know it's not quite too clear, but what this is saying is telling us that 24% of some states, 24% of the states represented here were yet to receive funds as at December 2020. Next slide, please. So these were some of the recommendations that we have made at that point based on the analysis that we did. And some of these include to advocate to commissioners of health for the completion of facility baseline assessment. That's for those states that they had not done their baseline assessment. And then also to advocate to commissioners of health in the affected states to activate their signatories for their TSE. So for this work that we had done, we were able to see at a glance what's happening in all the states. And then this tool served as an advocacy tool for CSOs as well as the media for them to be able to use this as an advocacy tool to conduct advocacy to the relevant stakeholders. Of course, for them to be able to use this tool, there were basic background trainings and then also mentoring a lot. So next slide, please. Okay, so this tool has also been used by the National Advocates for Health, CSOs, and the media. So this is just a brief of what we had done. So this is also very similar to what happened in 2019, but because this is a more recent version which happened in 2020, that's why we are presenting. We wouldn't want to present, similar thing that happened in 2019 as well. So thank you. Please send in your questions if you have any.
So thank you very much, African Budget Network. I think this is very, very exciting because we are looking at least getting very great information around transparency of inputs, in terms of how much is disbursed, how much is released, transparency of processes in terms of training, in terms of readiness of facility and the state, and then again, transparency of output in terms of how many facilities are getting the funds, and then Mama Ye help us in terms of transparency around outcome, how many people are accessing the services, how many people are accessing antenatal as a result of the basic care provision fund as much as possible. So we thank the two presenters for enlightening us. In all these, some things are very, very clear. We are making progress in terms of transparency. We need to make more progress in terms of use of those information for decision-making, engaging the key stakeholders. And maybe as time goes by, maybe when we meet sometimes next year, part of what we'll be discussing is that what is actually changing as a result of awareness that we are creating, increasing knowledge, our engagement, our advocacy, our questioning, what is it translating to? Have we mapped the change we want to see so that at the end of the day, we'll be able to know whether we are making progress. So another experience sharing from LISDA project. LISDA implements a global health advocacy incubator project in Kano, Lagos, and Abuja on financing epidemics, financing health security. So I would like to invite Kafaya to come and quickly make that presentation. Over to you.
Thank you very much, Dr. Gafara. So good afternoon, everyone. So today I will be sharing our experience and lessons learned in implementation of accountability frameworks in the health sector. So LISDA currently works on accountability in the health sector in 3 areas. So the first one is our support for the legislative network for universal health coverage. Currently, LISDA works with the LNU to implement their accountability, and oversight functions at the federal level and in
all the 36 states of the federation. So we work with the health committee of the National Assembly and the health committees of the state houses of assembly. Then we also implement the Prevent Epidemics project that is funded by the GHA, that's Global Health Advocacy Incubator. So for this, we work at the federal level in Lagos State and Kano State. Then we are also working on accountability for implementation of BHCPF on the state's governance and advocacy program, which is funded by BMGF. So this is also implemented in Kaduna and Gombe State. And we also have the federal level component of the project. So I'll start my presentation with the health security accountability framework, which I said we implement in 2 states and at the federal level. So as a form of background, we know quite clearly that mobilizing resources, I mean adequate resources this time, is a very important step towards strengthening the health security system, because wherever lack of funding is one of the reasons for poor health security system and even health security health system as a whole. So mobilizing adequate resources is very important at the national and the subnational levels. So it is in view of this that LISDEL is trying to advocate for increased funding for health security at the federal level and in the 2 states that I have mentioned. So what we do now? So why do we need to do this? So for resource mobilization efforts to lead to results, we need to ensure that there is value for the money that is being spent. And one of the ways in which this is done is to increase the accountability bar for resource mobilization and utilization of the funds that have been mobilized. So on the Prevent Epidemics project that we are implementing, we developed this accountability framework for health security in collaboration with HSRC, Budget, Nigeria Health Watch, and some other CSOs. And the accountability framework is built on the existing health accountability framework, which Dr. Gafara has shared with us earlier. So why did we need to develop this accountability framework? So it's to enable us to mobilize additional domestic resources for the health security, as we have realized that insufficient funding is part of the problem. Then also assess the effectiveness of the funds that are already being spent to ensure that the funds are actually yielding desired results. Then to improve efficiency in spending and support citizen participation in health security financing. So the accountability of Dr. Gafara has already described this, so I don't need to go through this again. So like I said earlier, the accountability framework actually looks very, very close to the health sector accountability framework. So here we have all the 3 components of accountability very well represented. We have the transparency aspect, the answerability and controllability components, which Dr. Gafara has adequately discussed with us. So on this side, we have the accountability indicators, starting from the amount budgeted out of the costed National Action Plan for Health Security. We want to know, we have a National Action Plan for Health Security, which needs to be implemented in 5 years. How much of this costed plan enters the budget for the year, and how much of it has actually been released? Then we want to know how much has been given to NCDC in terms of capital expenditure, capital budget, and how much was actually released. Then we also use this to track the overall funding of the health security, not just to NCDC. Then another indicator is the allocation to NCDC from the BHCPF, then the donor contribution and the private sector contribution. So these are the data that we're able to track
in year 2021. So for those that are not yet available, we have all the, we just left them. Then we have some other comments which we introduced, the data sources, the remarks, periodicity, how often will all this, will each of the indicators be tracked? Then we have the section for accountability actions. So okay, at the beginning, what we had was what we expected the legislatures, the executive, the CSOs, and the media to do. But on this page now, we have what these stakeholders have done so far in actualizing this accountability framework. Then I'll be discussing the outcomes next. So we started implementing this project in the year 2020. And in the course of implementing the accountability framework, we needed to know how much has been given to NCDC. So during our interactions with the NCDC and analysis of the budget, we realized that NCDC was not adequately funded at that time. So we embarked on several advocacy activities with some other CSOs. We had workshops, we had one-on-one meetings with the lawmakers, with the policymakers, even other CSOs and the media organizations. So at the end of the year 2020, when the 2021 budget was released, NCDC got an increase of 25% of their budget, and that we still continue the advocacy even in 2021. And by the end of 2022, NCDC was able to get another 31% increase in their budget. And this is what we have in, So this is what we have in this graph. You can see how it goes, then how it went up towards 2022. So another thing that we realized during the implementation of this, because we actually wanted to track how much the NCDC was getting from the BHCPF, then we realized that NCDC had actually been removed from the BHCPF guideline. Then another round of advocacy continued. We met with the Minister of Health, met with the lawmakers. It got to a point where we realized that the National Health Act needed to be amended to be able to accommodate the health security funding. So we worked with some other civil society organizations and partners to support the National Assembly, especially the Senate, to amend the National Health Act. The process is still ongoing. It has not been done. But the good news here is that even though the National Health Act has not been amended, a provision for allocating 1.25% of the BHCPF to NCDC is already in place. Then again, we, like I said earlier, that on the accountability framework, we want to track the amount of funds or the overall funds that are allocated to all the health security implementing MDAs. And as we know, it's not only NCDC that is implementing the National Action Plan for Health Security, because we actually practice One Health here, where all the other sectors are put, all the sectors come together to implement the plan. So on tracking what has been allocated to all these agencies, there are about more than 20 of them, about 26, I think. So we realized that apart from NCDC, it's only a few of them that were getting funds for the activities that are assigned to them on the National Action Plan. So we now started another round of advocacy, working with the NCDC, because the NCDC is the coordinating agency for health security in Nigeria. So we worked with the NCDC, Nigeria Health Watch, and other. So we went on advocacy visits to the MDAs. We visited the leaderships of these MDAs to discuss the importance of budgeting for their assigned activities. So after that, we held a workshop with all of them, all the 19 technical areas of the National Action Plan. We had a workshop where they all developed their 2022 work plan and their 2022 budget. So after that, we followed up with the Budget Office and the National Assembly to ensure that the funds, the budgets were approved. So at the end, when the approved budget was released, we realized that about additional 39 with 3.9 billion naira was allocated to, that's cumulatively now, to the NAPS implementing MDAs. And most of these things, most of the budget items are actually newly created. They were newly created in the year 2022. Then in Kano State, when we got to Kano in year 2020, we realized that Kano did not even have a budget line for health security at all. So they just respond when there's an issue, they just respond. So we formed a coalition for advocacy in Kano State. We joined hands with the CSOs and the media organizations who are very, very effective in the state. So after our advocacy actions, the state created a budget line for epidemic preparedness and response and allocated 300 million naira in their 2021 budget. But while they allocated 300 million naira, only 30 million naira was released in that year. So which brought us to another round of advocacy to ensure that this year, 2022, they release more than 10% of their allocation. They actually increased their allocation for 2022 to 400 million. But while that sounds like good news, it is the release of the fund that is actually what is important to us. So we are currently working with them to develop their release memos, follow up with the approving authorities. Then we're also working with them to get a standing order for releasing the epidemic preparedness and response funds every month. So that is still work in progress. Then then we also realize that they don't have a strong policy framework for health security in the state. So we have supported them to conduct JE, working with NCDC now and LAFIA project. We supported them to conduct the joint external evaluation, which now culminated into domesticating the NAPS in their state. So they now have a draft Kano State Action Plan for Health Security. Then we also realized that they don't have a strong legal framework for health security in the state as well. So working with LAFIA project, the CSOs and the rest, they now have a draft public health bill, which is currently being reviewed as well. So then in Lagos State, so we started working in Lagos State last year, 2021 in April. So on getting there, we found that Lagos State actually has a budget for health security. But the only issue with the budget line is that it focuses more on response than preparedness. And we know how important it is to actually prepare for epidemics. So we started advocacy with their coalition of CSOs and media organizations. Then a new budget line, public health epidemics, was created in their 2022 budget, and they allocated about 5 billion naira. That's the overall, the personnel, overhead, and capital for that, for year 2022. And so far, they have approved the release of 87 million naira, and which is yet to be cashed back. And we are still trying to advocate for the release of this fund because they budgeted for it on their own. Then we also found that they don't have a strong policy framework for health security. So they are also about to conduct their JE, that's joint external evaluation, which will actually show areas where they are having issues and also support them. It will help them to be able to cost adequately for what they need to do, the amount they need to allocate to this budget line instead of just allocating arbitrarily. Then we also worked with their lawmakers, that's the Committee on Health of the House of Assembly. We worked with them to include health security in their legislative health agenda so that they will include accountability and oversight for health security in their agenda. So that's what we have done so far on the Prevent Epidemics project. So while we were doing all this, the journey wasn't so smooth. There were challenges. There were minor ones and there is a major one. And the major challenge that we had was access to real-time data it was difficult for us to get data. Some data were clearly not available, while some were available, but they were not, we could not get permission to access them. So to resolve this, we had to work with the stakeholders too, because there was no how we're going to get that data without them. So we had a workshop earlier this year in January with the stakeholders from the Ministry of Health, from the NAPS implementing MDAs, from the Budget Office, Ministry of Finance, at the national level, then in Kano and Lagos. They were all invited to the workshop. And what we now discussed, we had to discuss the indicators, that they should look at these indicators very well and let us know the indicators that we may not be able to get data for, or those that we may have difficulty getting data. So after the workshop, we're able to review and streamline the indicators to ensure that only those that we had a high likelihood of getting data to populate them were retained on this framework. We also discussed with them on the approaches for accessing the data, because we were actually working so hard to get data. We worked with budget to do this, but we weren't just getting sufficient data. And they were able to tell us the approach that we should use to access this data at their own levels. Then we also discussed how we'll be able to get this data through legitimate means, not that someone will give us data and say, please don't tell anybody that I'm the one that gave you. So we are working on that. Even in Kano State, I think we have already surmounted that. In Lagos State, we're able to get the approval of the Commissioner for Health. So now we have access to the data in Lagos State. So we've been able to populate the Kano State Action Plan Accountability Framework. We are populating the one for Lagos, and at the national level, we have populated the one for 2021 as well. So that will be all now for the Health Security Accountability Framework. So I'll move to the strengthening accountability for BHCPF implementation. So this project started recently. I'll just be taking us through what we have done and what our expectations are on this project. So what we are doing here, we have 5 steps that we are following at the federal and state levels, where we work in Gombe, like I said earlier, and Kaduna State, and Lagos as well. So the first step is to identify all the stakeholders that are currently working on accountability for BHCPF, the CSOs, media organizations, development partners, even the government partners, to identify them, meet with them, have discussions with them. The second stage is to have a session where we all have a shared understanding of the objectives and the priorities of BHCPF. Like Dr. Kavara said the other time, that the first step to advocacy and to accountability is for us to all know what we are looking for. So for that, we want everybody, all the stakeholders, to have a shared understanding of what is expected, what's the work plan like, what are the inputs necessary, what are the outcomes that are expected. Then we now work with all the other CSOs to develop a citizen-led accountability framework for BHCPF. That's an overarching one, which is why we are here today. This is a step towards achieving this. Then when this is done, we'll now facilitate the tracking of all the indicators that are added to the accountability framework. Then when we get this data, like Doctor said the other time, we don't just get the data and keep quiet. We want to use the data, we want to act. So based on what we are able to get from the tracking, then we generate evidence for advocacy actions. We conduct advocacy actions, then we disseminate learning with other stakeholders so that they know what we have done, what are our achievements, and what are the issues that need to be raised, and those that need to be resolved too. So this is what we have done so far in Kaduna, Gombe, and Lagos State. In Kaduna State, the state already had an existing BHCPF accountability framework, which the Lafia project supported them to develop. So what LISDL did was to review the accountability framework based on the indicators from the BHCPF implementation guideline, specifically the M&E framework of the guideline. And that's the revised accountability framework has been validated by the relevant stakeholders, and CADMAM will be giving us more information about the Kaduna State Accountability Framework. I wouldn't want to go deeply into that. Then in Gombe State, we have developed an accountability framework for BHCPF, which is about to be validated. Then in Lagos, the accountability framework for BHCPF in Lagos State will be developed by 24th and 25th of this month. Then in federal level, it is ongoing. What we are doing here today is part of the steps for developing the overarching accountability framework for the national level. So this is what the accountability framework that was developed in Kaduna looks like. So we have the so we'll be tracking at the LGA and the state level. Then the themes that the accountability framework is focusing on are funding, governance, program management. Then we have the indicators. This is just one of the indicators. So we have several indicators. Then we have the target. What do we expect? Then the data source, where are we expected to get the data, and the responsible entity, who is responsible for doing this. And in fact, we'll even drill down to the point of the responsible person so that we know who to be held accountable at each point. Then the data collection frequency. So they will know those that are to be collected quarterly, monthly, and annually. Then after developing the accountability framework, a work plan was developed for it. Like Dr. said the other time, when you get something, then you must act. So to make acting easier for us, so a work plan has been developed, and it's also in line with the themes for the accountability framework: funding, governance, and program management. So we have the objectives for each activity in the framework. We have the objective, the target audience, the timeline for implementing the activities, who is responsible, then the indicators to be tracked, then the resources that are required to do that, then what will the outcome look like? So after all this, there are some issues that we would want everybody to consider here, which we have actually been ruminating over among ourselves. So the first is on integrating the accountability framework frameworks that are being developed by the different gateways. We are aware that the NHIS gateway has its own, the NPHCDA, the medical emergency. So, and we are here developing the citizens-led accountability framework. So there should be a time when these accountability frameworks will be integrated. So which organization will be responsible for this? Someone has to lead this process. So please, this is something we need to ponder over. Then another one is the need for sustainability. Now, LISDL is supporting, BMGF is supporting, some other donors are supporting the implementation of accountability framework. When these donors are no longer supporting, how will this accountability framework be implemented going forward? Please, this is something that these are the two issues that we are thinking of that we would want us to also add into whatever we are discussing in this meeting. Thank you very much for listening.
Okay, thank you very much for that presentation on accountability perspective from health security financing. I'm sure people who have questions, please note your questions. We'll take questions, including the virtual participants as well. So we have only one more to go. But before that one, that is Kadma from Kaduna, right? Do we have that representative? Okay, you are there. Thank you very much. Before your presentation, the Africa Health Budget Network, they miss out a slide, which is very, very important, which is on lessons learned. So, yeah, so you can, okay, please help her to put Health Budgets Network. She missed out the slide on lessons learned.
So sorry for feeding you all with a disjointed presentation. I don't know how I managed to miss out the very important aspect of the presentation, which is key lessons learned from that performance scorecard which I presented. So far, we can speak to 3 key lessons that we've learned from the whole process. Firstly, the scorecard development and implementation have been found to be very useful in promoting accountability and transparency of basic healthcare provision fund finances, disbursement, as well as the utilization. Secondly, the advocacy and engagement with MPHCDA were very productive. It has enhanced building trust and also consensus between our team and theirs. And then lastly, the MPHCDA has established a partners forum on basic healthcare provision fund to promote regular dialogue and access to information. So this very last one is very important. So we now have more like a platform where we can actually interact with them and get the information we need to do more of this work going forward. Thank you.
Okay, Jamila, that's from Cadman.
My name is Jamila Muhammad Tahir. I'm presenting on behalf of Kaduna Maternal Accountability Mechanism. I'm the Secretary, Knowledge Management and Communication. My presentation will be short because my sister here took us through a bit of some of the activities we did regarding basic healthcare, or we are doing regarding basic healthcare provision funds. So as she mentioned earlier, we at Kaduna State, we have already developed basic healthcare provision funds last year, accountability framework last year. But then let me take us through. Okay, so CADMAM. Please, next. Yeah. So CADMAM is a multi-stakeholder mechanism comprising of members from group of civil society organizations, religious bodies, professional bodies, traditional rulers, media, and representatives of government, MDAs in the health sector. What we do at CADMAM is to promote transparency and accountability, also influence positive health outcomes in Kaduna State. And we do that through advocacy, sensitization, evidence generation, and media coverage, among other things that we do. In CADMAM, we have 3 committees responsible for executing those activities. We have the evidence generation, who are responsible for data gathering, because what we do at CADMAM is evidence advocacy and stuff like that. We also have the advocacy subcommittee, who are responsible for going for advocacies when the need arises. And then we have the knowledge and management communication subcommittee, which manages the communication aspect of all our activities. Next slide. So far, these are just a brief of some of the activities that we do at CADMAM, and some of the success stories is improvement in transparency, access to health sector information in Kaduna State. We have been able to achieve that, like I mentioned, through evidence generation, advocacy, among other things. We've seen the government being inclusive. Most of the policies are now data-driven. We've also seen a situation where civil society representations is included in the policy reform committees and even board, maybe committees and so on of the health sector. We have also been able to improve some of the major service-driven successes is the renovation of the 255 PHCs in Kaduna State, employment of the 3,000 health personnel in Kaduna State, and the increment of the health budget in Kaduna State, which is even more than the 16% Abuja declaration, which were all part of the advocacies by CADMAM. So briefly on advocacy on basic healthcare provision funds. When the basic healthcare provision funds was implemented in Kaduna State, CADMAM was fully part of the implementation as the state-led accountability mechanism. So some of the activities that we conducted. Yes, please, next. Next slide, please. Yes, okay. Okay, so go back a bit, sorry. So part of the activities that were conducted by CADMAM regarding basic healthcare provision funds is a spot checks on the utilization of basic healthcare provision funds was done last year. And we shared the findings of the spot checks with the stakeholders, Ministry of Health, the 3 gateways. We also conducted advocacy visits regarding the key findings. Part of some of the findings were the underutilization of the funds. Even when the funds were released to the various basic healthcare, PHCs, we understood that some of these PHCs were just stocking the funds, were not even using it because they lack knowledge of drafting of the business plan, et cetera, et cetera. We have also understood some of this, that some of the basic, even the minimum PHC requirements in some of the PHCs were not realized. So we had to even also go back to the Ministry of Health, the gateways, to advocate for such findings, including also that there's lack of coordination among the gateways, the 3 gateways. So we had to even bring the 3 gateways together on a roundtable discussion, and we're able to achieve a better coordination. Now, most of them are doing things accordingly. And also, the development of basic healthcare provision funds was part of the activities conducted by CADMAM regarding basic healthcare provision funds implementation in Kaduna State. Next slide. So what process was followed while developing the basic healthcare provision funds? First, we did planning meetings and discussions. This is to understand even what the basic healthcare provision is accountability framework is all about. Some of us are not health sector specialists, or let's say we don't fully understand. We wouldn't fully understand what entails of the different gateways. So there was this like a coordination meeting with the 3 gateways and the oversight committee as headed by the Honorable Commissioner of Health in Kaduna State. And in that meeting, we were able to design, so to say, how to develop the accountability framework. The second stage was to review Chapter 7 of the Basic Healthcare Provision Guideline, because we understood that that's where the accountability framework is actually stated in the, about the accountability framework is stated in the guideline. So in that, we were able to, the 3 gateways, the 2 gateways. Now, why am I mentioning 2 instead of 3? Is because we understand in Kaduna State that the emergency component is not very strong as regards the implementation of basic healthcare provision funds. So we're focusing more on the state primary healthcare development agency and the contributory health board. So during the review, they were able to highlight the aspects of the basic healthcare provision funds to include in the accountability framework. And then there was presentation of the status of implementation of basic healthcare provision funds in the state by the two gateways and the State Ministry of Health. In that, we're able to have presentation by the Department of Project Research and Statistics on the monitoring and evaluation components of the basic healthcare provision fund, so that we'll be able to include that in the accountability framework. Then the last but not the least, and the most tasking part, was the drafting of the accountability framework. In that, we're able to design the accountability framework, which was just shared by my colleague here. The accountability framework, and we did that based on the guideline, the chapter 3 guideline, and chapter 7, sorry, and then the implementation of basic healthcare provision funds, the indicators in the state. And also looking at the presentation made by the Department of Research and Statistics at the State Ministry of Health. There were several reviews and validations. Part of one was supported by many partners, including Pearl and Lafia. One of it was also done last month by Lisdell, where we had to include additional indicators because we understood that the first one were lacking some of the indicators, and so we had to review it and validate and adopt just last week. Yes. So this is basically what the accountability framework looked like, as was shared by my colleague here. So we have just the level, we look at the state, both the state and the local government level. We have the theme, looking at 3 themes: funding, program management, and governance. The indicators, we have about 27. Before, we have only 15. So there were additional indicators that after review by Lisdell. And so we've included all those. That was presented by my colleague. Yes. So what about the implementation of the basic healthcare provision funds accountability framework, the previous one? As I mentioned, it was just drafted last year towards the end of the year. And so the implementation only happened just towards the end, just late December and then early this year, before the coming of Lisdell. And the process, we had to develop an accountability action plan for implementation. So development of the action plan also took these processes. The first one was also meeting with the different stakeholders to agree that we are supposed to come together to come up with the implementation plan. The next was identification of also the activities. We had to agree. Yeah, please go back. Yes, and then we drafted the action plan and then we began to implement. I want to quickly share here that, so in the implementation, yes, please move to the next one. So this is what the implementation plan looked like. So you have the activity, you have the objective, target, outcome, the timeline, responsible person, indicator, resources required, and budget outlook. And we've implemented some of these activities towards end of last year, around December, and then early this year. I'll be mentioning some of the challenges and lessons learned quickly. So lessons. We understood that it requires clear understanding of the operational processes involved in the implementation of basic healthcare provision funds across the gateways. Some of the terms you need to understand, some of the processes you need to understand to be able to draft the activities, to be able to follow up with the activities effectively. The second point is it requires time and processes to do a great job. If I mentioned earlier that the first draft, we missed out a lot of the indicators. So it has to be reviewed. And thankfully, Lisa was around just a few months ago, and then we come up with something. And that's why it has to be reviewed maybe periodically, then it is highly important to involve the state actors at every stage. Sometimes during the process, we will develop something, but during validation, we will understand from the different stakeholders, because we have to invite the three gateways, for instance, the two gateways, sorry, and they will explain that, oh, this indicator does not belong to us, or it belongs to the other one, or it's not even saying anything. So you have to take your time to be able to come up with a great job. It is also important to involve many CSOs, media, coalition, and partners within a geographical space. This is because while drafting the first basic accountability, basic healthcare provision funds accountability framework, we understood that also another partner was supporting another coalition to develop another accountability framework. So this is very important when you have invite different stakeholders from the different CSOs within the geographical area to come up with one accountability framework so that you can take and continue the work together. And funding was an issue, just as was mentioned earlier. We couldn't continue with the work, the implementation, because the partner that supported us before exited. I'm talking about Lafia. So unfortunately, we had to stop, even though we continue with some of the activities that the accountability mechanism can continue, but it is important that there's funding to be able to support those activities that will be outlined in the accountability framework. Last but not the least is the closure of partnership. That's for sustainability. It's part of the problem we have with the funding, the logistics issues and all. So recommendation is, first of all, to have a technical committee that will guide the process. I mentioned issues about understanding of the technical terms regarding the accountability framework. The process should be properly planned in terms of timing, because it requires a lot of time, processes. So you need to plan very well to be able to work properly. Involve all the gateways right from the beginning of the process so that there will be ownership. So at this stage, CADMAM is still talking about which of the gateways will host or will take the responsibility of the accountability framework, because we harmonize all the accountability, the framework harmonizes all the accountability framework, sorry, look at all the two gateways in the state. So if, for instance, we are talking about Primary Healthcare Development Agency, and they might say something like, what about the component of the contributory health agency, since it doesn't concern them? So, but when you do that together, there will be a house, for instance, for the accountability framework to be able to monitor effectively, to implement effectively, because as civil societies, you cannot do that without the government side of it. Then involve as many CSOs, media, coalition, and partners. This is to solve the issue of having one accountability framework on an issue or for basic healthcare provision funds, since that's why we are here together. Ensure multiple sources of funding to be able to tackle the issue of logistics and other things that might arise. Garner support from as many partners as possible so that you'll be able to have sustainability or plans for review and other stuff, so that one person will not be, or one partner will not be overburdened, and you'll be leaving out some aspect of the accountability framework mistakenly. So that's all from CADMAM, just the experience about how we did it. Thank you.
So let's appreciate all the presenters once more. So we would like to use the next half hour to discuss, to take question, contribution, clarification from the presenters. This time around, I would like to start with our online participants. I know some of you put question in the chat box, but if there's anybody that wants to speak to the speak directly, please raise up your hand so that our secretariat can unmute you so that you can contribute. But while we are doing that, okay, Amy, have you harvested the questions from the online participants? Okay, we are seeing the process of doing that. As any of them are raised up, these are hands to contribute. Anyone yet? The online participants? Okay, so while they are still trying to make up their minds, let's take questions and contribution. So please, when you ask question, please direct it to specific presenter, and let's just make it brief as much as possible. Thank you.
Thank you so much, and well done for the brilliant presentations. I don't know whether it's a question or comment or a prayer, but let me just put it this way. I've seen a concern from a particular presentation that data mining and inflow is a challenge. While on the other presentation, I've seen them working with the government partners, and that make it easy for them to have data flow. So I think I would like to advise some level of cross-learning among the partners. That's number one. Number two, I look at all the presentation. To me, we are just like tracking traffic of the funding. Are we really looking at utilization? It's an area that we need to really also focus. And that will create some activities for the CVOs at the facility level. And then finally, it seems like, I don't know, I could be wrong. We need to harmonize these tools so that we have a harmonized tool, and it will make it easier for sustainability and then for efficiency. Thank you.
Great questions. Before we go to the next one, I think you asked very, very important questions around harmonizing tools, but at the same time, cross-learning among various organizations. So the good news is that in the next section after this is a group work that will look at what are the factors that facilitate and inhibit a successful accountability store. So that's a very, very good opportunity for learning among our partners. Any other questions, clarification, contributions? Okay. Okay, Alice asking question. Probably the sugar level is getting low.
Okay, thank you, everyone. Thank you to all the presenters for a very good job. Just maybe to ride on what the last speaker said, looking at what we've been able to see from the different presenters, there are a lot of efforts, both in terms of funding, in terms of technical expertise, in terms of the tools that someone spoke about. That is actually happening in the States, all with a view to developing accountability framework for BHCPF. And I think it will be important, like he said, for us to harmonize, to synergize our efforts, and maybe find a way of working together, key into what each other is doing, because at the end of the day, we may just have multiplicity of tools, multiplicity of frameworks. This one is doing their own, this one is doing their own. But if you can find a platform, for example, I have the intention of talking to Madam later, because we have a new investment and we are moving into Kaduna. We are already in Kaduna, in fact, because we've identified an office, we have a focal, we have a manager there. So any moment we're moving into Kaduna, and we are like going to do the same work. You understand? So we need to speak to each other. So I think this forum should actually open up opportunity for us to learn about what each other is doing. How do we harmonize, synergize, and see? And also, I don't know, I don't want to preempt what is going to happen maybe before the end of this workshop, but I think there's need for us to, especially for those organizations that have been supporting the national program, National Primary Care Development Agency, to see a way where we can maybe have a national framework or a national accountability framework, because it's not just these states where partners are working. All the 36 states are implementing BHCPF. And it's like, well, if you have a partner working, you may be at an advantage. If you don't have a partner working, what happens to you? You understand? So if we can put all our efforts together, support the national, to see if we can have a national accountability framework, that each state can key into and adapt to their own situation. I think that would be very helpful. The other one is a question to the last presenter. The first slide you showed, very good, very excellent. But pardon me for my M&E mentality. When I see impact, I'm always shaking and say, whoa, so we are there already. So maybe that's just a matter of choice of word. But for us in M&E, when we see impact, it's a sort of a high level achievement that is actually difficult for just one person or one organization or one institution to achieve. We are all working towards contributing to the expected impact that maybe Nigeria as a country has set for itself. So, like I said, that might just be a choice of word, but when I looked at them, they are just what I can say achievements and results that are different levels, and they are very good. Thank you.
So thank you very much, Ali. You are absolutely correct. What we are working towards is to have harmonized tool. Probably I forgot to mention at the beginning of the section or today. I think, so we have a 2-day section. Today is about harnessing experiences from different partners and looking at the framework so that to set the stage for a conversation tomorrow around the basic care provision fund accountability framework. Probably that is the national framework we are talking about from the side of the citizen. Of course, the various agencies are involved. We have their own check and balances in place. So you're absolutely correct. So today what we are doing is to listen to everybody. And I'm quite happy that a lot of things are happening, which make us to have, and hello, I'm going to hold you accountable, please. So that we are going to have a robust and comprehensive system. And you're absolutely correct. It's not only about where we have partners. There are a lot of states now, you'll be wondering, in fact, we have to hold the external financing landscape accountable. If you go to a place, you want to go to Kaduna now. In my state, nobody is supporting the state. Everybody wants to go to Kano. Everybody wants to Kaduna. Everybody wants to go to Lagos. What of numerous other states? Maybe it's not the responsibility of partner, but government should take the responsibility as well to ensure that all the states are well covered. Thank you very much. Any other question, contribution? Anybody from the online that want to speak? Okay, so we have invested. So let me be sure that we are done with the questions from the participant in-house as well. Any other question, contributions? Yeah. So, okay. Yeah, you can. So we have invested the online. Okay, Dr. Gore wants to say something.
Yes, I just wanted to make my general observation, something that we should all think about. First, I look at the social sector. When it comes to expenditure from government, we look at the health sector and the education sector. But I will say that the education sector has been far more successful than the health sector in terms of getting financing. First is the fact that when they established UBEC, Universal Basic Education Commission, the government approved 2% of the consolidated revenue fund for them. And they have been using this fund for close to 20 years. And they have a lot of experiences where they're implementing the utilization of these funds at the state level. In fact, put in another way, the Basic Healthcare Provision Fund is just like an imitation of what the health sector did. And we have 1%, they have 2%. At the same time, they have this education tax, which is getting funds for the TED fund. And this education tax, TED fund, their budget is more than 200 billion every year. In the health sector, we are still battling with is it 20 or 40 billion from our Basic Healthcare Provision Fund. So what I want to say is that we have to learn a lot of lessons from the education sector. And even more important, very relevant to this section here is that they have been implementing this basic healthcare provision, they have been implementing their UBEC funding at the state level over the past 20 years. There are a lot of lessons, a lot of pitfalls, how they have been able to get the states to do their counterpart funding and all that, how they have their own accountability framework, how have they been getting along? I think we should have equally looked beyond the health sector and see what is happening in this, how they are managing, and if we share the experiences too. I think that will help us. Thank you very much.
Thank you very much, Dr. Celestine. Abubakar Mohammed is online. He's raising up his hand. Can you unmute him, please? Abubakar Mohammed.
Yeah, thank you very much. Yes, I can. I'm unmuted. Can somebody confirm that you can hear me, please? Hello, can you hear me? Am I being heard? Can somebody confirm?
Yes, you can go ahead, Abubakar.
All right, thank you very much. Just to appreciate all the presenters, actually very, very great content, highly enlightening. Just two comments, right? Not very specific to a particular presenter. The first comment is around just an observation, a general observation around the nature of content that is being presented, right? I see most of the content is around generating evidence and making sure that we have all of the information, all of the data that tells us all the inputs, all the processes, and maybe sometimes even outputs of or regarding where we are in terms of the BHCPF implementation. I think we may need to also think about how best to socialize this data that we're generating with the populace, right? I think since we're talking about accountability, and we've kind of set the stage very, very clearly from the first presentation, that the first thing we need in terms of accountability is information, right? So how do we make sure that when we generate this information, we don't just use it within the inner cycle of the health system? How do we make sure that we also socialize it with the populace and help them have, or maybe arm them with the necessary information that they require to start holding people responsible in terms of the accountability we're talking about? We can talk about how best to do that, maybe through town halls or other means, but I think it's important to start thinking about how best to do that, right? And number two is regarding the need for very close collaboration between organizations that work more closely on accountability, like the CADMAM, right? With organizations or partners that are more involved in service delivery and financing. I'm really glad to note all of the beautiful work that CADMAM is doing in Kaduna. We as CHAI, I've even forgotten to introduce myself. My name is Abubakar Mohammed. I work with CHAI Clinton Health Access Initiative, and we support Kaduna State to implement BHCPF as well. So it will be interesting if we can identify some of these areas of collaboration or synergy among ourselves. Like, for example, we've kind of generated significant number of service delivery information from our end. So it will be very interesting if we can share and collaborate with CSOs that work on accountability, just so that we can leverage our strengths for good. Yeah, I think these are the 2 points I wanted to contribute. Thank you.
All right, Abubakar, thank you very much. I can assure you that after this workshop, there will be expansion of the coalition. People will definitely be more aware of what we are doing concerning this accountability framework. And I'm sure more stakeholders will get involved in building one. I hope the presenters noted some of the points gave and the questions. But let me just read this from Kenneth Adagba. He said, oh, I'm sorry, the phone is not mine. The phone is off. Okay, while I sort this out, can we just present? Okay, does anyone of the presenters, do you want, okay, thank you. Okay, it said, although they did not, it did not indicate who exactly he was directing his question to. He said, under risk, the presenter said political interference is one of the risks. Can he give some examples of what he meant by political interference and suggestions on how to minimize this risk? I wouldn't know the exact presenter. Then Peter Osaji from Options. He said, nice presentation. How were you able to access the data on service utilization of basic healthcare provision fund? Was it directly from the selected healthcare financing, or how easy was it to track referrals to secondary care? Sorry, was it from the selected healthcare facility, or how easy was it to track referral to secondary care? Then Tari Asuka, he said, just like in the days of getting the National Health Act enacted, beyond overt advocacy and engaging with relevant actors, is there something we are missing? Then someone asked, Ahmed Abdusalam asked, what is the EMT fund under Basic Healthcare Provision Fund used for? Is there any visible evidence for that? Then the last question from the same Ahmed Abdusalam, why advocating for NCDC to have allocation under Basic Healthcare Provision Fund? Does the Basic Healthcare Provision Fund cover epidemic preparedness and response? So who, among the presenters, who spoke about the risk?
Okay, thank you. I think I will respond to the question on the referral, because I know I showed one of the indicators that the BHCPF scorecard track as percentage of referrals from the primary healthcare to the secondary healthcare. So what that means is we all know that the primary healthcare facilities are the nearest facilities to our communities. And one of the key areas where health workers are actually trained and as part of their profession is to be able to identify cases that are danger, that they are not able to handle, and be able to refer quickly to the nearest higher level of care. And so the essence of tracking this is to see the level of professionalism that is being exhibited by the healthcare workers at the health facility, at the primary health facility level, so that they are able to save lives as much as possible. And so that, if I understand that question very well, though, actually the referral is because at the primary healthcare level, the next level is the secondary facility. So is the most of the healthcare facilities, primary healthcare facilities, have secondary facilities where in sort of their catchment area where they are closest to, and are always encouraged to refer cases that are beyond their capacity to manage as quickly as possible. So that's what the level of professionalism that the Basic Healthcare Provision Fund is trying to track, to ensure that the facilities are able to provide the kind of services they are able to provide, and are able to make referrals to save lives as appropriate as possible. I hope I've answered the question. Thank you.
Thank you very much. I will just take one more question from online, and that's Harriet Edumo. Please, can you unmute Harriet Edumo?
Good afternoon, everyone. Thank you for the wonderful presentation. Very insightful, very, very educative, and very, very informative. Thank you very much. But I just want to add the basic healthcare provision fund supposed to add to the provision of services at the what level, or what do I say, at the primary healthcare level, primary healthcare facility. But working with the primary healthcare facilities and at the state level, funding for primary healthcare is not very clear. It's not really very clear. We don't know whether it's a state funding, local government funding, and it's just at the mercy of whosoever wants to bring out the money. Is there anything that we can do? Just this question came about when somebody was talking about learning from education, looking at what education is doing regard to funding for primary education. Is there anything that we can do regards to the primary healthcare so that we will be clear about funding for the primary healthcare, where money is coming from, and who is actually responsible for funding, and how this money is supposed to be, and it's very clear, so that when we are tracking, we know that, okay, this is the person that's supposed to be, I know that we all agree that it's supposed to be the local government that should do it, but then we also have the primary healthcare under one roof, which is move everything and they not move money. So I don't really know whether there's anything we can do in that domain. Thank you very much.
Thank you very much, Harriet. Okay, Harriet, please, the MPACDA gateways, another gateways will be around tomorrow. Probably we'll be able to give better clarification to your question tomorrow. And the same thing goes to some of the questions I asked earlier online, like for the EMT, please let us be patient. Okay, sorry, someone from MPACDA is here and wants to respond. Thank you.
Thank you very much. Regarding the question, she asked about the funding. I don't know which state she's coming from. The way she asked the question, because it's transparent, I think all the states are aware about the trainings we did and the operation guidelines made clear explanation on that. And again, we have the MPACDA handbook that if that is why I asked which state they are coming from, if they are really working with the state primary healthcare development agency, you have the handbook where it explains everything from the national, the source of the funding, the way up to the health facility level, and what those funds will be used for. So that is it about it. And I have some observations about the presentations made by partners, and even though we have discussed with her, the AHBN, I think they need to update those slides. There are so many things that have changed. All those places, we have 6 rows that are showing red under training, capacity building, and I'm in charge of capacity building. It has been completed in almost all the states except River State in Nigeria. So all are now green. And then also on baseline assessments, we have seen some states where we have red. There is no states that have not conducted that we have not conducted a baseline assessment. So there are so many changes on that their scorecard, and she agreed to work on that. Okay, another one, the E4A, evidence for action. Some of the presentations, I don't know when it was developed, whether that's the most recent presentations they also have, because I happen to be in Bauchi and I'm the focal officer for Bauchi State. So I'm hearing slums for the first time. Slums, do they really work with the states? You know, it's very good when partners are in states to work with the people, go to the state primary health care board or state health insurance and contributory health insurance than just working. You will not get so many information if we don't do that. We need to have a partners forum that will also work with the gateways so that informations will be shared and it will make our work easy. Thank you.
Thank you very much. I don't know if Ifo wants to respond to that. But before you respond, please, I will employ our online participants. Please, whenever you are writing or your question in the chat, please indicate. It will help if you really indicate the person exactly who you are referring the question to. Thank you.
Okay, so madam, in Bauchi, we said Islam is state-led accountability mechanism. So they will now call them BASAM, Bauchi State-Led Accountability Mechanism. And like I said, this team comprises of government. Now, on the government side, as far as BHCPF is concerned, representatives of all the gateways are members of this team. We have a State Primary Healthcare Development Agency. We have the contributory State Health Management Contributory Agency and some other ones. So all of them are part of this team and they work together as an accountability mechanism. So they call them BASAM. You understand? So that's the way, and we work with them. So working with them indirectly means, or directly means we are working with all the gateways. We are working with each of the agencies that are, ministries and agencies that are involved in the implementation of BHCPF. And not only BHCPF, but we're actually, like I said in my introduction, we're into all maternal and newborn health activities. Thank you.
All right, thank you. I just want to throw more light on some of the questions that were raised, especially on the issues of the EMT gateway and the NCDC gateway. The question was, what's EMT gateway all about and whether it is also functional? Yes, it has not commenced actually, but a lot of work is going on. What is it all about? It's basically to provide ambulance services for medical emergencies. And how is expected to work here is that ambulances will be assembled just the way the Bolt or Uber is being done. And in the event of emergency, you call a certain set number, and then an ambulance will be sent to that point. And then it will also move the person to an accredited health center. It is expected that treatment will be given to the person within 48 hours of payment. However, after the first 48 hours, it will be expected that the payment mechanism comes into place. And then it is basically for all Nigerians. The services is for all Nigerians, but for payment from the EMT gateway is for the poor and indigents. That is after services or is covered by NHIS, formal sector, informal sector, and what have you. If he's not, then whether he's able to pay. If he's not able to pay, then the EMT gateway will now reimburse that services that have been rendered. So we expect that any moment from now, some states will commence services. They've actually launched the manual sometimes in February this year by the Honorable Minister of Health in Abuja here. And then since the manual is ready, we expected that many states will commence implementation. Then on the issue of the NCDC gateway, why is NCD gateway part of the Basic Healthcare Provision Fund? I want to believe that it is because of the emergency medical treatment gateway that is in the Basic Healthcare Provision Fund. However, when the law that established the National Center for Disease Control was enacted, Section 14, subsection 2G states that 2.5% of the 50% basic healthcare provision fund will be used for NCDC. What that one means is that with the enactment of the NCDC law, it has consequentially amended the National Health Act to mean that 2.5% of the 50% basic healthcare provision fund. It means there was a 50%, but it means there was a 50% and the 50% will be taken from that of the NHIS. But if the law has stated that is 2.5% of 50%, that will have been taken from the total amount of money. So as it is, it has consequentially amended the National Health Act, and monies have actually been deducted. The last payment that was paid in December, monies for NCDC have actually been deducted, but they have not started the implementation because they don't have a manual. So we're expecting the stakeholders to gather, have a manual, and anytime the need arises for public health security and medical emergencies, they can come and take and utilize the money. Thank you.
Thank you very much, Dr. Okara. Our time is fast spent, but let me just allow the lady here, please, because she has a question.
Thank you. My question is for Dr. Gafar. In your presentation, you had a slide where you closely related number of consultations per person per year to financial constraints. Now, I would like to know if on that slide specifically, there was a study done in a particular health facility. And that's because when you disaggregate data, you might find that there are many reasons for low number of consultations per person per year. For example, if you look at pregnant women and choice of where to deliver, many of such studies exist, you'll find that many of them opt to deliver at home, but they cite reasons such as their perception of poor quality of care in the health facility, long waiting periods at the health facility, which can be attributed to inadequate human resource for health, etc. So I'd like to know how you make that very close association between number of consultations per person per year and financial constraints. Thank you.
Dr. Gafar answers the question. Dr. Henry?
Like I said, it's a minute. Tomorrow, God giving us the grace, keeping us alive, maybe I will speak more. It is only in this country, perhaps, that people start looking for money in government circles. They start looking at budgets of organizations. So this agency, this MDA, they have money. They go and poke their fingers there. 5% of the basic healthcare provision fund was made for emergency medical treatment. Go and check the act. Why? It was last of the minute intervention. We went for public hearing. Senator Kowa, who is now Delta governor, was the chairman committee of health. National Assembly has enacted one law. They say doctors must treat anybody without payment. How is it possible? NMA delegation went, took some other stakeholders, said, how do we do this? Say, please, let us ask them for 5% of this fund to cover for the vulnerable. But we have to define, at that public hearing, the problem is what is emergency medical treatment? Because in this country, people come to hospital by 2 a.m. with eczema that started 2 years ago. They say it's emergency. It's me, now it's worrying me. So that was how this thing came about. Now NCDC now said emergency medical treatment is now health emergency. They should give them half. Whether it has consequentially or impliedly amended National Health Act is another case. Those that are thinking that ambulance system will work without one, proper addresses, labeling of houses, locations. 2, national identification number, or what do they call it in other countries? Everybody has this security, personal something security number. How many are we? Who is vulnerable? Who is poor? So we keep on shouting. What of the hospital you are rushing this person? Are they, how are they working? Do they have gloves? Do they have cotton wool? Or your own is to rush them, oh, this one is bleeding, you dump her there. You think you have done your bit. Let us wake up. We are either copying wrongly or pasting wrongly, and that is bad.
Dr. Henry has spoken.
Okay, thank you very much. And thanks, Dr. Henry, for the passion. And something that all of us need to do is that is because we did a study and we interviewed Dr. Henry. That's how we knew the genesis of emergency gateways. It was actually Nigerian Medical Association that carried placard and say, as you are developing basic care provision funds, you have to make a provision for the emergency gateway. But having said that, health security too is very important. COVID has told us how health security can rubbish every other thing that we have done in the health system. So all of those aspects are important as well, Doctor. So answering your question specifically in terms of a consultation per person per year, I think what we just did and what I present is more of observation rather than drawing inference in terms of the fact behind figures. So what I present now is the figure, what we observe. But basically what we do is like looking at different cohorts of population in the facility that we support. We look at those people that are not on any health insurance at all. We look at those that are on basic care provision fund. We look at those that are benefiting from equity fund. And we look at those that are benefiting from donor supported health insurance subsidization. And we now follow the cohorts and we look at the utilization among those different cohorts. And we try to see in terms of who are those people that are utilizing services more, without necessarily relating it to their, whether it is financial barrier. Now you and I know that if I don't have health insurance and I'm not getting access to care, and you give me health insurance and the whatever, at least there's an association. Even if we are not able to say this is an attribution. You understand? Those people that do impact evaluation will be able to build me out in terms of how I use those nomenclature. So that is what you have just done. And it's just to tell us what is actually changing as a result of subsidization. If I have health insurance, how many times am I able to go to health? I know there are a lot of several other factors that determine whether or not I will use that facility. But to me, I think the common variable, the variable that is different among all of them is health insurance subsidization. So maybe we may need to do a more rigorous study. I would like to engage you to help doing that as much as possible. So before we finish the question and answer section, just a couple of contribution. So from where I sat there, there's a suggestion that across the gateways, the handlers of the gateway should try as much as possible to make available their various manuals, and so that people will understand the processes of these various gateway, MPS, NHIs. Of course, there's a national guideline, but different gateways have detailed manual that describe their processes. Then to Dr. Okori, I believe there are a lot of things we can learn from education, and we have learned already. The fact that education was rigid about the counterpart funding, that's why billions of dollars are still sitting at the central bank that the state has not assessing as part of the UBEC fund. Am I correct? And that is what informed the relative flexibility of the basic care provision fund in terms of managing the issue of counterpart funding. If you ask Dr. Okara there, they are trying to find a way of saying, okay, because initially they too wanted to be rigid. The former minister said, okay, we've learned from basic, from UBEC and all those stuff, let's devise a way. Later on, people said we are breaking the law. Then later on, we now see the reality, and then even probably the law will change to align with the reality now as much as possible. So Again, I think in terms of accountability, we have to advise our colleagues in education to raise the accountability bar. You talk about TED fund. TED fund, billions of dollars sitting in central bank, money meant for education research at higher institutions. Do you know what? Most of our lecturers are not able to write proposal to access the fund to do the research. And ASU is always on strike. Bring more money, bring more money. What of the money that federal government has already made provision for that is sitting in the central bank? If SATI is no longer here from the budget office, do you know that the federal government is not even borrowing out of that money? Because the lecturer are not accessing the money. But nobody is raising the accountability bar. When ASU is always going to strike, they shout. Even the federal government that's supposed to stand its ground is begging them. What of the money that is released already? What is the accountability? What is the money buying? You understand? So we have to raise the accountability by across board. It's not only in the health sector. And this is the information that many people don't have. Billions sitting at central bank. Because it's a statutory fund. You deduct it every year, you take it to the central bank. But the Nigerian lecturers are not able to access the funds. And that is why we are producing 18th century graduates that are looking for jobs in 21st century markets. Absolutely. So you now see the huge implication of this accountability that we are talking about. So having said that, enough for lamentation. So we have to, okay, Ifeoma, yeah, it's good to get married. You are looking so different. Huh?
Sorry, I just, I don't know, an observation. Mimuna presented something on the scorecard, accountability scorecard, and then a lady also mentioned that we had passed that, they had passed the level where of what she presented. Then my concern is this: if we're developing an accountability framework and we are not constantly following up or measuring what has been done, I would have assumed that by now they would have done an updated, that we will have updated reports or data on what is happening at the state. Now, if we're not doing that, we can have an accountability framework that we're not using, thereby truncating the aim of what we are to do. We should also look at the challenges. Is it that they are not going? Is it funding that is the challenge? Is it unavailability of data? Is it bureaucracy with agreeing to go or not going? Okay, if they have collected the data, is it capacity to analyze or make this data available to the public? As we're looking at the accountability framework, it will also be really nice if we ensure that we resolve some of the challenges that might arise from not having updated data to make informed decisions. Thank you.
Thank you very much, Ifeoma. So this is part of what we'll be looking at during the very short breakout section we'll be having very soon in terms of what works, what doesn't, and what should we do differently. So what we are going to do now, we are coming to the end of this section today gradually. So what we just need to do, we have listened to a series of presentation, contribution, questions, and answer sections. But what we need to do is that we want to harness in terms of what are the factors that either promote or inhibit successful accountability activities, and make recommendations in terms of this is a factor that inhibits maybe what cut across announced challenges across around generation of data and all those stuff like that. So if you identify those challenges or those factors, for example, engagement, effective engagement, relationship building, if it works in terms of helping us to get results for accountability, let's identify them. And for those that inhibit our work, let's identify them and make recommendations. I think that is what we are going to do now. I suggest probably, of course, Juliana that is going to handle that. Yes, that's your name is on it. You should be, we'll hold you accountable. So what I suggest is like, let's have like 4 groups, and those that have made presentation around various accountability. How many are they? Like 4, right? Or 5? One more presentation. Budget is not here today. Yeah. So we have 4. So can we have 4 groups? It's not going to be too large. Something. So, but in, okay.
since it's factors that in debate. Okay.
It's your whatever.
Thank you.
So,
hello, everyone. Should we stretch a bit? We've been sitting down for a while, right? Are we tired? Let's shake a little bit. Please get up. Who is good with what do they call that? Oh yeah, communication. All right. So let's stretch a bit. Please feel free. Nigerians are good at stretching, right? So I don't remember any of those, what do they call them again, that you do see and coconut. You spell coconut. Exactly, it's coming back. Now let's spell the coconut, please. And I know that everyone here is used to spelling coconut. C goes like this, right? Exactly. So let's do that. C, A. Oh, I don't know how to spell coconut. But that's my own. So let's spell A. Spell A. So let's spell O now. C again. If you're not pregnant anymore, please spell C. C, please. N. How do you spell N? U. T. Turn around. All right. I hope the virtual participants also did that. We've not had lunch yet, so it's a good thing. At least we won't sleep. Do we proceed to the group work? It should be quite short. Factors that facilitate, and please take a seat if you feel like it. One house, please. I'm glad to see that the room is energized now. Okay, so we are going to be, can we, Dr. Okpe, do we have post-its here? Are the post-its ready? Factors that facilitate and inhibit successful accountability initiatives. So we are going to be working as we are seated in groups. Where are my participants? Okay. All right, but I think we still will form a good quorum. Dr. Okara, one house, please. So we are going to be developing, we're going to be working on this maybe for the next 30 minutes, I think. It's not really, there's no what? So let's in our groups, please let's not move around. Let's discuss this. Everyone is going to have a post-it. I think we discuss and then write down factors by streams. If you want to say, for instance, based on the challenges that we've heard from each of the presentations so far, now across maybe funding, sustainability, but we are not going to prescribe to you. I think discuss it and let's have your own groupings or your own headings, and then what you will detail under each of those streams. To be interesting to see where we have similarities and where there are maybe divergence headings that are listed. We have 30 minutes, Dr. Gafar. How long do we have? We have 30 minutes, and then that's the last session for today. So if your co-group members have absconded, please join. Let's make up like Kafayat, please, madam. Can we join? Like let's form or join other tables so that we have. Thank you. So you have to choose someone to present for you. But why I'm asking for post-its, please maybe just whatever important things come to mind before you agree for one group, or as a group, just fill it out. I would like for us to put them to make the walls, to make this room a little bit colorful today. All right, thank you. How many online?
One. Okay. There is a point.
Okay, so online participants, please do us a favor. We are online virtually. We're not going to break into groups, but we'll really appreciate it if each participant, we still have about 28 participants online. If you would do us a favor of sending us your opinions or perspectives of what factors inhibit successful accountability initiatives. So maybe you could give like 4 bullet points. Thank you. And just send as into the chat room, please, as chat messages. We will finish by 3:15.
So true, funny how it seems, always in time, but never mind for dreams. Never the hills way to toe. This is the sound of my soul. This is the sound. Walk on a ticket to the world. But now I've come back again. Why do I find it hard to write the next line? Oh, I want the truth to be said. I know there's much so true. Funny how it seems, always in time, but never line for dreams. Head over heels, when toe to toe. This is the sound of my soul. This is the sound. I bought a ticket to the world, but now I've come back again. Why do I find it hard to write the next line? Oh, I want the truth to be said. I know this much is true. I know this much is true. With a thrill in my head and a pill on my tongue, there's open nerves that have just begun. Listening to Marvin all night long. This is the sound of my soul. This is the sound. Always slipping from my hands. Stands a time of its own. Take your seat, night out to write the next line. Oh, I want the truth to be known. I know this much is true. I know this much is true. I bought a ticket to the world, but now I've come back again. Why do I find it hard to write the next line? Oh, I want the truth to be said. I know this much is true.
We've done 15 minutes, so we should be done with the factors that facilitate by now. We have about 13 minutes to go. So we should be, I know we have a lot to discuss, but let's move to factors that inhibit now to make good time. Virtual participants, I hear we have only 2 out of the 28 who have responded. Please contribute. Thank you. Factors that inhibit and factors that facilitate.
so true. Funny how it seems always in time, but never in line for dreams. Head over heels, running toe to toe. This is the sound of my soul. This is the sound. I wanna take it to the world, but now I've come back again. Why do I find it hard to write the next line? Oh, I want the truth to be said. I know this much is true. I know this much is true. With a thrill in my head and a pill on my tongue, there's over nerves that just begun. Listening to more than all night long. This is the sound of my soul. This is the sound. Always slipping from my hands. Stands a time of its own. Take your seaside arms and write the next line. Oh, I want the truth to be known. I know this much is true. I know this much is true. I found a ticket to the world, but now I've come back again. Why do I find it hard to write the next line? Oh, I want the truth to be said. I know this much is true. I know this so true. Funny how it seems always in time, but never line for dreams. Head over heels, we're toe to toe. This is the sound of my soul. This is the sound. I want a ticket to the world, but now I've come back again. Why do I find it hard to write the next line? Oh, I want the truth to be said. I know this much is true. I know this much is true. With a thrill in my head and a pill on my tongue, there's over nerves that have just begun. Listening to Marvin all night long. This is the sound of my soul. This is the sound. Always slipping from my hands. Stands a time of its own. Take your seat, side on to write the next line. Oh, I want the truth to be known. I know this much is true. I know this much is true. I bought a ticket to the world, but now I've come back again. Why do I find it hard to write the next line? Oh, I want the truth to be said. I know this much is true. I know this much is true. This much is true. This much is true. This much is true.
Okay, hope it's going well. We have 3 minutes more. So when you are done, to my right-hand side, we have flip chart sheets, right? With the headings facilitate. So for each group, you find where your group, this section does not follow any chronological order. Here I have group 3, 4, 5, and there I have 1, 2, 6. So just find where your group is and post your post-its to your section. Same thing to my, this is left, right? All right, left. To my left, you have factors that inhibit. Please do the same thing. Thank you. TikTok, 2 minutes to go. So you will need to present. So those you choose to present will need to speak to it. You know, you have to go to where your summations or submissions are to present.
So true, funny how it seems, always in time, but never in line for dreams. There go the hills running toe to toe. This is the sound of my soul. This is the sound. What fun a ticket to the world. But now I've come back again. Why do I find it hard to write the next line? Oh, I want the truth to be said. I know this much is true. I know this much is true.
60, 59, 58. Those are seconds, not minutes. 57, 56, 55, 41, 40, 39, 38, 37, 20, 19, 18, just write 7 somewhere and put. 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Pens up, please. Let's present. Thank you very much. I'm sure it was very engaging and interactive and interesting. But time up. Which group is ready to present? Can the leads or the presenters please stand by each flip chart and let's present. Who are the leads? Group 1. Group 2. Group 3. Can the leads get up? A round of applause for each table, please. All right, thank you. Please, let's present. Group 3. I think you're ready to go. So please, let's hear from you.
Good afternoon again, everybody. So in our group, we think that most of the factors we identify can also go both ways. Like on the flip side, if they are there, they facilitate. If they are not there, they inhibit. So one of the first things that for facilitation, we think that first of all, if there is funding for, it's going to help us to really measure our accountability. For example, if we need to go in to collect data and there is no funding for logistics, for example, as little as that is, you could delay things over weeks, over months, and when we eventually do it, we know that what we call accurate data is it has to be timely. So when we eventually do it and it doesn't come in timely, what use will that be in decision making, which is at the end of the day what we're aiming for? Another thing we thought of is capacity. If we have the capacity so I'll just speak to both facilitation and inhibition at the same time. If we have the capacity to generate data, general data management, generate the data and analyze and then use it for decision making, it will go a long way in helping our accountability rates. If we do not have that capacity, how are we sure that the data we are even generating is accurate and reliable? If it is accurate and reliable, how are we sure that we can analyze this data to get the answers that we need? And do we have the capacity to use it to make informed decisions? So those are the things that can facilitate. If the capacity is not there, it inhibits our effort. But if this is there, it helps us completely. Another thing that we thought of is the availability of data. Now, we have gone into the field to get this data. If they are not available, probably at the facility level, they're not even keeping good records. There are no records at the facility. We don't have people giving us reliable information. How are we going to be able to say this is the status of things, or this is the way things are right now? That will inhibit or facilitate all of our efforts. Another thing that we thought of is political will, political interference, political interest. Where there is political will, is going to go a very, very long way in helping us facilitate. We can have all of these grand plans, but if there's no political will, everything is going to be grounded. And then another thing is the political interest or political interference. So for political interest, we might say this is going to be done here in Zone A, and then there's a senator who wants it to be done in Zone B because it is his area of his constituency or something. And then he moves, probably that place is already oversaturated with projects and the things they are doing. All of this will not help us towards achieving the ultimate goal. Then that's the political interference part. Then again, for funding too, there was something, I'm going back to funding now, where it is available. Sometimes these fundings are not used for what it is released for. Funding could be released for A and somehow it finds its way to C. And at the end of the day, we're not achieving results. Another thing is if we have multi-sectoral collaboration, where we are beyond the health sector. Okay, first of all, before we get into multi-sectoral collaboration, if all of us in the health sector who have a common goal, who want to achieve the same thing, come together to synergize our efforts, is going to help us greatly to achieve than people having parallel efforts, going in different directions to still arrive in the same destination. So if we all can come together, and like someone mentioned earlier, why not we harmonize all of this framework that is being developed by different persons? It will give us really, help us achieve our goals better. And then multi-sectoral collaboration beyond health. We need the media, we need the traditional rulers, we need people in different sectors. If we need to advocate for, we have the results, we need to advocate for change and ensure that things are done the right way. We need to collaborate with others. What else? Bureaucracy. Bureaucracy was another thing we think. If we have to do things from the beginning to the end, if there's bureaucracy, nothing moves. From the tiniest of them to the biggest of them, nothing works. Everything is grounded because someone has to wait for another person to make some decision and another to make another decision. At the end of the day, we're not making any progress. These are things we thought if they are there, they would help. Some of them will help to facilitate things. Where they are not there, we are grounded. It will help to inhibit our accountability efforts. Thank you.
A round of applause, please, for group 3. Perfect. Thank you. So please confirm, we have data reliability, comprehensiveness, authenticity, and availability. We have capacity, whether it's gaps or that we have enough to handle. Political will, interest, interference, funding, non-use for stated objectives, multi-sectorial collaboration. Synergy is important against duplication, and then on the other stream, beyond health to other sectors and gatekeepers, right? And then guarding against bureaucracy, right? All right. So other groups, do we have factors that are similar? So which one? Let me ask Eric it. Which group has similar?
Group 4.
Which ones are similar?
Bureaucracy.
Bureaucracy.
Yes.
Capacity.
Capacity, yes.
Yes.
We have poor collaboration and coordination among stakeholders.
Okay, so collaboration and coordination, right?
Yes. I think that's all.
Any more?
Yeah, political will.
Political will.
Yeah. It's okay, it's finished.
Group 5. Yes. Okay, so yes, I've asterisk it.
Political will.
Is also asterisk.
Yes.
Any more? Okay, so do you have others that are not stated here? Who has additional that are not stated? Okay,
Group 4.
All right, so group 4, please present.
Under the factors that inhibit, one of the points we have here, which has not been stated there, is translating evidence to action. Yes. It inhibits accountability initiative in the sense that before you carry out or implement accountability issue, you have to develop accountability framework. You are collecting data. After you have collected the data, you analyze it. You discover the stakeholders that are supposed to be held responsible for their actions and inactions. But if such if such evidence is not translated into action, it is an issue. Then under the factors that facilitate it, we have, capacity building has been mentioned, sustainability in the area of funding. Okay. When one of the presenters, she talked of they were carrying out accountability development of framework in one state, and at a point, the partner that was sponsoring them withdrew. That means the funding was not sustained and they couldn't continue. Then we have a strong political will. Strong political will. You may have a good accountability issue. A good accountability initiative. But if the political office holder that you are responsible to or that you are accountable to does not have a political will in support of that initiative, there's no way that, of course, that initiative will die. Yes. Yes, I think that is all.
Okay, so in addition to what has been mentioned, then we have credibility of implementing entity, credibility, like track records. So like the person in charge of that or the project that is trying to conduct that assessment, if they don't have good track record in the community, they may tend to be faced with problems while assessing the questionnaire or whatever they are trying to do. Credibility of the implementing institution, just like you have put it, is fine. That's the person, the partner that is doing that. or CSO or anybody doing it. So if they don't have that good record with the community or the stakeholders, the familiarity with the gatekeepers, that's another one. It's good. Okay, it can be both. It depends on how we interpret it. So if you are familiar with the gatekeeper, it's good because you'll be able to override a lot of protocol and all that. Then if the objective is not well stated, it's negative. So if it is well stated, if it is very clear and well communicated, then it's a plus. Then the last one we have here, it says transparency and adequate collaboration with government stakeholders to avoid suspicion, because if they're not sure of what you want to do, for instance, when you are asking for financial data, when you're not sure, they tend to see you as you are doing audit or you are doing investigation. So there is need to be transparent to get them well informed so that they can cooperate with you and give you the relevant information. Thank you.
Any more comments or contributions? What do we have online? Okay, so please come and present. I thought you had similar. You do?
Points.
So which of them? So anyone that's
But the
similar, please
difference,
don't
what we
present
have
it.
here different from
Which one?
theirs is we have a adequate knowledge of the agency's mandates.
Adequate knowledge of what?
Agency's mandates, which will help to facilitate or inhibit the process. Like the issue of the freedom of information, this is there for one to use to know most of the agency's mandates. But when you don't have access or you don't know what the information is all about, you wouldn't know what to do as to facilitate the process. Then the second one we have here is courage. This has to do with the CSOs. They need to have courage to ask questions and to use available documents. If you don't have that courage to ask questions as CSO, I don't know. Then the other part of it is judicial system. We all know what happens in our judicial system in our country. Cases are being referred almost every day, but they are not even trashed. So it either inhibits and it can also facilitate when one does not comply to court orders in favor of either the CSO or the agencies. So it stands as either to facilitate or inhibit the process. Then another point we have is corruption, which is tied to lack of transparency. Corruption, another point, yes. Corruption, yes, on the part of the agency and the CSOs too. Yes, like when money is appropriated for some projects, the agency that can decide to use such money for something different without reporting to the National Assembly.
Okay, so can we find a more objective way of cover-up of what?
Agencies' activities.
National Assembly, be careful where you say. So what other things
Leave it for us, corruption. Leave it, corruption. Sorry. Sorry, sir, for coming too close.
Sorry, let me put a little light on that.
Which one?
On this corruption issue. No. Just listen to me first. We know that we have a public accounts committee in the National Assembly, and they receive reports from all MDAs. And when we talk about corruptions, some of these MDAs come and they hide some of their documents. We have some agencies who are receiving, they are collecting, revenue collecting agencies. And this, they have the capacity to retain some funds, and they don't disclose these funds. Then also on the part of National Assembly, they also have the capacity to discover these things. And you now see the elements of collusion, and they look the other way. And that is how these things come about. That is why we emphasize that corruption is an inhibitor. Thank you.
Example, retention fees.
I'm sure that every one of us is corrupt to one degree or the other. So when you jump queues, you are corrupt. Whether you jump it by telling someone, by shunting, particularly fuel queues, or when you go to the bank or ATM and you shunt, you are corrupt. All right, so thank you so much for this. Let me just go through. We said credibility. I already read the one before, so let me save time. Credibility of implementing institution. So when we say implementing institution, we mean implementing the accountability framework, familiarity with gatekeepers, however you want to see it. It can, I would say maybe stakeholder management. So your relationship with the relevant gatekeepers can either open, give you access to those that you want access to, or inhibit it. Need for well-communicated objectives. So as a coalition or CSO or media or efficiency tracking agency or institution, are your objectives for tracking, that's whatever tracking you're doing, is it clear to those that you're working with to track, right? Or to say how efficient is your system in respect of basic healthcare provision fund. Transparency is important, and adequate collaboration with the government as well as the gatekeepers, as we have talked about. Knowledge of the mandates of the MDAs, or even ourselves, or whatever institution that you're meant to be checking accountability. So whether is the National Assembly or the CSOs or media, you will do well to study and conduct research on not just the mandates and objectives of that particular institution, but to even have more information about public expenditure management. How are they managing their resources? You know, have your ear to the ground as well as being able to research. Courage, we have corruption. We've spoken about that clearly. We have courage, right? So when you know what I would want to tie that to also understanding the landscape of wherever you're operating in, and always being armed, you know, go extra to know what is going on, and then you'd be able to speak, and whatever angle a question is thrown, you would be able to respond accordingly. With that, I would want to add mine. It helps when we are courteous as well. So just because we are CSOs does not mean that that's not a free pass to be rude or disrespectful. I think that there are ways that we can communicate what we want to communicate without being aggressive necessarily. Judicial systems, I don't quite understand what the judiciary has to do with this. I think perhaps we want to talk about sanctions, right? And actually like punitive measures in quote for institutions or offices that default. Basically, I don't know whether it goes up to the judicial system. And perhaps also, maybe what you mean by this is also where we have an act or a law that prescribes what we should do, like for the Basic Healthcare Provision Fund, are there sanctions, right, for defaulting people as well? I guess that's what you're trying to say. And of course, the almighty misappropriation of funding. Are we happy with this? Okay, Dr. Okpe? Which ones? Oh, so you want to, they've not been mentioned before. Dr. Okpe, would you please read out just a second what we have from virtual participants? So what are the two you want to add? And evaluation and reward. Evaluation and reward. Don't mind my writing, but I'm sure it's better than most of the doctors here. Better than the writings of most of the doctors. Dr. Gafar's writing, you can't read it.
So for the, just some that I think are a bit different from the online from the online participants, unclear expectation, that's for inhibitors, unclear expectations or outcomes. Yeah, or outcomes. Administrative bottleneck, of course, the government bureaucracies and bottleneck. Then they also mentioned lack of technology and automated accountability frameworks. I think, yeah, we go there. Yeah. And lack of technology and automated accountability framework, which is fine. Yeah.
This is all. Give me another. I think Juliana deserves louder applause, please. Thank you very much. I think we've done very, very well. And looking at part of the objective that was set for ourselves, I think we have accomplished a lot today. Can we appreciate ourselves once more? So on this note, I will give us an overview of how we are progressing, and what we want to do tomorrow. So like I said earlier on, today we are setting the stage in terms of understanding accountability framework, listening to partners to know what they are doing, the lessons they've learned, which will now help us to develop, to look at what are the key elements. What are the key elements of Basic Care Provision Fund Accountability Framework? So tomorrow, we are going to, after the recap, we are going to listen to, hello, one house, please. We are going to listen to the various gateways. Because, like I said earlier on, our accountability framework is going to be a hybrid of different types. So we are looking at what the various gateways are doing. We'll listen to them. We are going to have a panel discussion to further x-ray what are the key accountability elements. We are going to have a group work to design this. And at the same time, we are going to look at develop an action plan to show that what next, what should we do differently so that we are going to achieve the objective of this accountability framework. So before we close for the day, because Dr. Okore will just go give us the last words for today, because we have done very well, because part of the element of accountability framework is reward and sanction. But because we have done very well, we are entitled to the reward, and the reward is going to be a beautiful lunch. So we deserve lunch as a result of the good work that we've done. And it's not only lunch that we deserve group picture as well, group photograph. So we are going to take a group photograph after this section, and we are going to have take our lunch, and that is the reward for the great work that we have just done tomorrow. So if we repeat same tomorrow, I think we'll be entitled to breakfast and lunch as well. So on this note, I would like to once again thank you very much for the participation. And I thank our online participants as well. They are still very there since the morning. They've contributed, share experiences. They've asked questions as well. And hello, one house, please. And they've shared experiences as much as possible that contribute to the richness of these events. Please, let's try as much as possible to come early today. We started behind schedule today. We didn't start until after 10 o'clock, though we agree we are going to start at 9 o'clock. So let's come at 9 o'clock so that we are very rich. Tomorrow's section is extremely important. Today we just set the stage. It's tomorrow that we're going to dive deeper into the discussion on Basic Care Provision Fund Accountability Framework. So on this note, I would like to hand over to Dr. Celeste Okorie to give us the last words for today. Then we are going to, what is the plan for the group photograph, please? Well, anyway, where do we assemble for the group photograph? Okay, so because of the banner, we are going to the stage there, right? Okay, that's great, yeah. So, Dr. Okorie, over to you, sir.
Hello. First, I have to thank Dr. Jafar Alawode and me for anchoring this today's meeting. Jafar has done a wonderful job. There's no doubt about that. And we very much appreciate him for what he has done for us today. I also have to thank all of you for coming. And I wish you a wonderful day. And we look forward to seeing you tomorrow. Tomorrow, just like Dr. Jafar said, is going to be very crucial because we have set the stage today. And tomorrow we are going to have to hear from the gateways, their experiences, and it's going to be quite enriching to all of us. So thank you very much for coming. We are going to have the group photograph and have something to eat. And I look forward to seeing all of you tomorrow. Thank you very much. Okay.
Please, can we have the picture in front here? I think there is the best place. Please, can we do this quick?
So true, funny how it seems, always in time, but never in line for dreams. Head over heels, running toe to toe. This is the sound of my soul. This is the sound. I wanna take it through the world. But now I've come back again. Why do I find it hard to write the next line? Oh, I want the truth to be said. I know there's much is true. I know there's This is the sound of my soul. This is the sound. Always slipping from my hands.
Please, can we come out and take the group picture? Please come out and let's take the group picture.
So let's have the council of elders in the front there. While the rest of us join them at the back. Yeah. Oh yeah. Okay. We might need to put some more chairs just to support like this. Let's put more chairs. Let's close in those whatever and put more chairs in the front. Let's close it up. Yeah. You're welcome. Yeah. So we want to be gender sensitive, madam, in front, please. Yeah. So please, Madam Juliana, you belong to the Council of Elders. Huh? So let's move forward, please. Let's. I'll sit here. So please let's have the group pictures quickly, please. Dr. Okara, please, we need you up there. So let's, yeah, exactly. We have. It doesn't matter. Yeah. So Dr. Okara, come and have your seat over there. And yeah. Yes, sir. So what will you call me? Yeah. Madam. Okay. Okay, thank you very much. The lunch is served, so let's grab our lunch and have a very, very good lunch. Thank you.
This is the sound of my soul. This is the sound. I wanna take it to the world, but now I've come back again. Why do I find it hard to write the next line? Oh, I want the truth to be said. This is the sound